Can you hear me? Hello? Okay. So can you hear me? Good evening to all of you. If you can hear me, just give me a thumbs up so I can be sure when we can start right now. Anyone, give me a thumbs up if you can see me properly, if you can hear me. I'm waiting for your signal so that I can start at 6 o'clock. Perfect. So today, first of all, how are you? How are you doing? How are your INICET preparations going on? I hope they're going to be at their full swing. The zeal, the zenith, the enthusiasm would be at its peak, and there would be a small component of the fear. Fear is also very important because it shows that you're really interested in your subject. So today, what we'll be doing is, after this 20-day of prepathon that we've been going through, today is the turn for radiology. Now, radiology is one of those subjects which is very closely integrated with almost every branch of clinical medicine, and in the recent days, radiology and image-based questions have found their number increasing in day-to-day exams, particularly the NEET PG and the INICET. So in the last 19 days, we've talked about a number of other subjects, and I think we at Manipal Days have helped you, made your journey easier while going through INICET. Now the question is what we're going to do today. And today we'll be talking about radiology system-wise. We'll be talking about one system followed by other system. And I'll just give you a brief overview of what we'll be talking about in the next 2 hours. In the next 2 hours, we'll be talking about one important MCQ, which is a PYQ. We'll be dissecting that. Then we'll be talking about the entire subject, and then we'll be coming back to the high yield topics from the same subject. So this is how we're going to talk about in the next 2 hours. The next 2 hours are going to be full of fun, energy, enthusiasm, and a lot of knowledge. So let's begin our discussion. The first subject that we're going to take today is women's imaging. And our first question that we have with us is this one. Now, this is a very important previous year question. And the question says, which of the following is an indication of first trimester sonography? To understand this, we should know what is the first trimester sonography. Whenever a female gets pregnant, obviously, she wants to know whether she's pregnant or not. So the first scan that we're going to do is going to be done at the time when she first misses her periods. That is at around 6 weeks of gestation. Why? Because we want to know whether there is a pregnancy or not. And if there is a pregnancy, where is it located? It's in the uterus, it's ectopic, or whether there's a pregnancy which is anywhere else in the abdomen. So the first scan is the dating scan. I hope everybody knows about it. The second important scan, which some of you might have heard of, in fact by now almost everybody of you would have heard of, is NT-NB scan. Good evening everybody. Good evening Meenakshi sir. Good evening Dr. Dhanalakshmi. So NT-NB, what does NT-NB stand for? Anyone? What does NT mean? NT stands for a very, very important scan that we do in first trimester sonography. That's done between 11 to 13 weeks and 6 days. Good evening, Jamula. Can you tell me what does NT stand for? NB is easy. NB stands for nasal bone. Fine. And NT stands for nuchal translucency. Now the question is, why are we so much interested in knowing about nuchal translucency and nasal bone? Can anybody tell me what are these two things representing, or in which disease do we find abnormalities with the nasal bone or nuchal translucency? Now this is a very easy question. I hope everybody of you will be knowing it, but just a quick revision. Is there any syndrome that we want to rule out by looking at the nasal bone? Yes. The syndrome is trisomy 21, that is Down syndrome. Now, we have to measure NT and we have to look at NB. Normal nuchal translucency is less than 3 mm. So the first trimester sonography consists of a dating scan that we do at 6 weeks. It consists of an NT-NB scan that is done to look at aneuploidies. So now let's look at the options, what we have in front of us. Confirmation of pregnancy, yes. Gestational age, obviously when the patient gets pregnant, she wants to know what the gestational age of the baby is. Screening for aneuploidy, yes. This NT and NB scan, which is done between 11 weeks to 13 weeks, 6 days, gives us a lot of information about the risk for Down syndrome. Now, there are two other options, that is diagnosis of placenta previa and checking for fetal presentation. Placenta is not formed actually in the first trimester. In the 10-11 weeks, it's not much formed. And secondly, we can't comment on previa. We comment on previa only in the third trimester. So that's out of question. Secondly, looking for fetal presentation, does it really make sense? Why do we want to know the fetal position? We want to know fetal position only when the Childbirth is going to occur, whether the presentation is cephalic, breech, what is the type of maneuver that we're going to follow. So for these two, we do not want to have a look on the first trimester. Perhaps we're going to look at both of them in the third trimester. So the answer in this case is A. Perfect, Jamula, you're correct. That's A. So keeping this base question in our mind, let us quickly revise some of the important topics, important high yield information about women's imaging. First of all, let's talk about the chronology. Now I've set you four things: yolk sac, gestational sac, fetal heart rate, and embryo. Let's call that number 1, 2, 3, and 4. Now can anybody tell me what is the first thing to appear? Yolk sac, gestational sac, fetal heart rate, or embryo? Now that's an easy one. Now to understand this, I've told you before, you just have to just imagine what do you do when you shift into a new home. You buy a new flat. What do you do? First thing that we do is we get a home for ourselves. Very good. That's gestational side. Jamula, you're correct. Second thing is, once you get a home, you get into a flat, what do you look for? You get all the antiques arranged. You get the kitchen arranged, you get the sink arranged, you get the bathroom arranged, everything which is required for you to live inside. So second thing that we want is the nutrition. How do we get nutrition? From the kitchen, obviously. Third thing, when everything is into place, you move inside the home. So that is you, that is the embryo. The king of the place who has to live inside that place will walk around. And once the embryo comes, the embryo is going to take his heart along with it in the gestational sac of the home. So now the correct order. Can anybody tell me what is the first? You've already answered that. That's going to be the gestational sac. What is the second one going to be? Perfect, Jamula. That's right. The second thing has to be the yolk sac. So the order has to be 2 followed by 1 followed by embryo followed by heart rate. Now, one thing which is also asked in your exams is what is the appropriate age at which we will be asked? Sakshi, you're correct. So we get gestational sac on a transvaginal scan between 4 to 4.5 weeks of pregnancy. Just keep on adding 1 and you're going to get the answer for the rest of the others. Yolk sac 5 to 5.5. Then embryo, that is going to come between 6 to 6.5, and fetal heart rate is also got around 6 to 7 weeks. Now, one more question that is asked. You're all correct. You have all got it correct. You're perfect with it. Now, another question that is asked is the sequence of the different examinations that we do. So, we've already talked about the dating scan. We've already talked about NT-NB. Now, I'll tell you 3 different scans more. One is a level 2 or TIFA. Next one is fetal echo. And last is Doppler. Tell me what is done at the earliest amongst the 3. First is dating scan, second is NT-NB. What is the third one? Level 2, fetal echo or Doppler. And when do we do it? And what is level 2 actually give information about? I'm waiting for your answer. Now that's going to be an easy one. Fine. Anybody? Dating we've already talked about, KK. Yes, perfect, Jamula. That's going to be a TIFA scan. Now what is the time that we do it? It is done between 18 to 22 weeks to look for intricate fetal anomalies. We want to do it before 20 weeks because if there is an anomaly, we want to abort the fetus then and there. If we do it at 30 weeks of gestation, there's no use of picking an anomaly. Fetal echo, it is done slightly late. Fetal echo is done at 22 to 24 weeks. And finally, we have our Doppler scan. What do we do Doppler for? Doppler is done for the blood flow. And when do we need to check the blood flow or the growth of the fetus? In the late third trimester. So we do Doppler in the end, mind you, and that is done around 30 weeks of gestation. Now I hope this entire chronology is going to be clear with everybody. If it is clear with everybody, let us move towards our next set of images. Now these are 3 important image based questions. Let me call this number 1, number 2, number 3. I want you to tell me from image number 1, what is this sign? Is it a sign of pregnancy or not? I'll give you a hint. All the 3 are signs of early pregnancy. What is this first sign showing us? Fast, tell me, I'm waiting. What do you see here? Let me magnify this image for you. What is it? Do you see anything inside the uterus? It is a transvaginal sonography. I think everybody of you would have picked up. This is the uterus, and inside the uterus we can see this structure. So what is the structure? Anyone? I'm waiting. I also want you to answer me second and the third images. This third one is a previous year question, so should be correct. Perfect, Sakshi. That's a gestational sac. Why it is a gestational sac? Because it is located eccentrically. Now, this is another very important question that is asked. Gestational sac is never central. If it is a central sac, it is a pseudo sac. Because the fetus should be attached to the wall of the decidua only, then it is going to get blood flow and nutrition. So, this is the gestational sac, and this sign is called by the name of intradecidual sac sign. Why? Because the sac is seen within the decidua. This is the first one. Now, and what do you see in the second image? You can see two different echogenic or bright layers around the embryo or the gestational sac. What is this sign called as? I hope you know this sign. This sign is, again, this represents two layers of the decidua. Because there are two layers of decidua, it is a double decidual sign. And just type what are the two layers of decidua which form the double decidual sign. I'll give you a hint. That is something which has got to do with a personal computer PC. In the meanwhile, let's look at this particular image. What do we see here? A previous year question. This is an image that should be etched into your minds. You should not forget this. What are we looking at? We are looking at two different sacs. One sac is this, the other sac is this. They are appearing as two different blebs. So what do we call this? Come on. Use your brains. Tell me. This is an important thing. You shouldn't be missing this one. Where's your energy? Come on. Tell me what is this? I don't want you to just mug up the two things. Both of them are dual things. This is something else. This is something else. Anybody? First image number 2. What are these two decidua representing? P for what? C for what? Okay, the one is paritalis, the other is capsularis. Now they form the two layers of decidua, the paritalis and the capsularis. While this is a double bleb sign, and double bleb sign refers to two different blebs. One of them is the amniotic sac, the other is the yolk sac. And if you see carefully, let me just clear this mess for you. Then here you can also see the embryo. There is the embryo which is lying within the amniotic sac. Yes, KK, you're perfect. That is double bleb sign. You got it correct. Now, let's talk about the best dating parameters. So before I go ahead, I want you to know what are the dating parameters we are having. We have CRL, number 1. The second one, we have femoral length, abdominal circumference, biparietal diameter. And if we ask about all of them, then all of them have their own significance. Let's first talk about the first trimester. What is the best parameter for dating in first trimester? Tell me. CRL, femoral length, abdominal circumference, or biparietal diameter? Can we measure FL, AC, or BPD in first trimester? No, that's an embryo. An embryo is something like this that I just showed you here. Can you measure the femoral length of this embryo? No. Perfect, Sakshi. This is the reason why it's CRL. In second trimester, we have femoral length also, we have abdominal circumference, we have BPD, that is head circumference or BPD also. So what is going to be the best in second trimester? Now, I'll give you a hint. We can never use abdominal circumference because if you put the pressure with the probe, then abdominal circumference can be changed anytime. Yeah, yes, you correct, Dr. Dhanalakshmi. So second trimester, we can either use femoral length or we can use biparietal diameter. Now tell me which of the following are we going to use? FL or BPD? Sakshi said it's femoral length, but I don't agree with you, Sakshi. Now, at the time of early second trimester, the femur is going to be very small. So, when you measure it, you can get a lot of technical difficulty in measuring it correctly. Yes, this is the reason why we use biparietal diameter in second trimester. What we'll be using in third trimester? We have two options only. Abdominal circumference is already out of the question. We can either use FL or we can use BPD. So, what will we use in third trimester? In third trimester, in a normal cephalic presentation, where will the head lie? Head will go down into the maternal pelvis, and obviously it is not only difficult to focus it, but you can compress it so you can get fallacious readings. So for third trimester, Sakshi, your answer is correct. It should be femoral length. Overall, best time for dating, remember, is always the first trimester. Why? Because if the patient suffers IUGR and you keep on measuring it in second or third trimester, anyhow it is going to go wrong. So in the first trimester, the best dating is done. And what is the tool that we have in first trimester? I've just talked about it. We have only one tool, that is CRL. So the answer is going to be CRL. Now, the easiest question. What is the best parameter to assess fetal weight or macrosomia? So where is your maximum weight lying, all of you? It lies in our belly. So for fetal weight, obviously the answer is going to be abdominal circumference. For rest of them, abdominal circumference is not going to be answered. I hope this is going to be clear to you, conceptual and easy. So now let's go on to our next part, twin pregnancy. In twin pregnancy, only two questions can be asked to you. KK, you're correct. That's abdominal circumference. So first one is this and second one is this. So this is the second trimester signs of twin pregnancy. I want you to tell me which of the following is showing a twin peak sign, lambda sign. That is image number 1. Is it showing twin peak or lambda sign? Or image number 2 is showing a twin peak or lambda sign? Come on, I'm waiting. Where do you see the lambda? Lambda. I know the Josh is high. Almost all the answers that I've asked you, questions I've asked you, you've come up with the right answer. So I'm expecting a right answer here also. I'll give you time. Where do you see the lambda sign? That's not difficult. You just need to focus on the placenta. Sakshi, KK, anybody? I'm waiting for you. Where are you looking at the lambda sign? So KK says this is lambda. Sakshi says first is T and second. Both of them are sure that this is lambda sign. So let me just show you the sign. So this sign here we see the placenta is coming like this and this placenta is going like this. So does it look like a lambda or does it look like a T? And if we look at the second one, we see this sign and this sign. So where do you find a T and where do you find a lambda? Now I think it's going to be clear with all of you. This is the lambda sign. Both of you were wrong. This is a T sign. Now the question is, the examiner is going to ask you which is lambda, which is T sign. The examiner is going to ask you which of the following represents a diamniotic dichorionic pregnancy and which represents a diamniotic monochorionic. Obviously, because we can see an amniotic membrane, so there are two amniotic cavities in both of them. But here you see a placenta is growing on both sides. So this is the reason why it's a lambda sign. So this is a diamniotic dichorionic pregnancy. So you can remember it by D. If both the things are going to be D, it's going to be lambda sign. While this T sign is for diamniotic but monochorionic pregnancy. Here one thing I want to tell you, in first trimester, amnionicity is measured by yolk sac. If there is going to be one yolk sac, monoamniotic, two yolk sacs, diamniotic, and chorionicity in first trimester is measured by gestational sacs. If one asks you what is the best time for diamniotic, monoamniotic and all these difficult things, that is also the first trimester. Similar for the as for the gestation age. Sakshi is correct. Sakshi says monochorionic, diamniotic, perfect, T sign. Now let's look at some of the ANC spotters. Now I want you to tell me the answers to these questions. Probably these spotters you might have seen in your forensic medicine session also. So let me give you the hint in these questions. The examiner is going to give you that there's a pregnant female who's not feeling fetal movements. In fact, I saw this case around 2 weeks back only, and this is a very, I should say, a sad condition both for the doctor and for the baby. What do you see here? It's an ultrasound done in an ANC, and this is the fetal head. I hope everybody of you would be looking at it. It is fetal head. Why? Because we are seeing white bones. Now bones are going to be white on ultrasound, bones are going to be white on X-ray, and bones are going to be white on CT, but they're going to be black on MRI. We'll discuss that later on. So what is this part? What is this area which is being focused? What is that thing which contains bones all around and it is almost ellipsoidal or oval in shape? What part of the fetal body you think about it? Both these conditions, image number 1 and 2, are showing you the same thing. Can you tell me what it is? It is a condition which is associated with diagnosis. Tell me the diagnosis first, and then I want you to tell me the sign. Anybody? No fetal movements felt by the mother along with bleeding per vaginum. What is the diagnosis? The diagnosis here is IUD. And what is the sign that you see? You see the overlapping of fetal bones called as a Spalding sign. So that's a Spalding sign. I hope you know this. This is an important one. You shouldn't forget it. It is an important spotter that can be asked. It's a previous year question. Second, if I tell you that it is fetal abdomen, what do you see here? You must have seen this image in your forensic also. You can see multiple white spots all throughout the fetal abdomen. What does white spot mean in the abdomen? Yes, KK, you're right. That's Spalding sign. What is this thing? If you answered Spalding, then you should tell this thing also. Both of these signs are signs of intrauterine fetal demise. I'm waiting. Air means white. Air is white on ultrasound. So it means that there is air in the abdominal cavity. There is air in the veins. No, that's not stomach bubble. Bubble is going to be like this, and bubble is not going to show air. In fetus, air is not going to come inside the abdomen whatsoever. Air will never be inside the fetal abdomen in a normal abdomen. If air is coming inside the abdomen, it means there is something gone wrong with the fetus. It's a case of fetal demise. Air will come into the great vessels also, and this is a sign which is called by the name of Roberts sign. So I hope you will always remember these two signs, Spalding and Roberts sign. Next one. What I'm showing, first of all, I've given you 3 images. Image number 1, image number 2, image number 3, and for some reason I've shown you banana, I've shown you a lemon, and I'm showing you Arnold Schwarzenegger. Now I want you to just join all the dots together and tell me what the diagnosis is. Anybody? It's going to be very interesting one. You'll remember this forever if you know this right now. Tell me, can you make the diagnosis? What has Arnold Schwarzenegger got to do with lemon, banana, and all these 3 images in question. This is again a previous year question. Should be knowing everything. Perfect. KK has come up with the answer. He says banana is a sign for spina bifida. So let me tell you what the things are we looking at. This is the fetal brain or fetal head, and we can see some bifrontal indentation. So bifrontal indentation is looking just like a lemon. So that's called a lemon sign. The fetal cerebellum looks like, in fact, if you look at the cerebellum here, that looks like a banana. And icing on the cake, we can see some cystic structure which has been marked by a lumbar spine. So we can see a meningomyelocele as well. Whenever you see this lemon sign, if even somebody asks you, sorry, banana sign, about this banana sign. So what do Pahlwans do in India just to get their body? They eat a lot of bananas. Banana is eaten by Arnold Schwarzenegger to get a good body, and Arnold Schwarzenegger stands for Arnold Chiari type 2 malformation. Remember, Arnold Chiari type 2 malformation is associated with all those features, three features: banana sign, lemon sign, and spina bifida. I hope you're going to be remembering this for the rest of your life. Next one. Good evening, Dr. Abhinami. Next spotter, what do you look at? Now again, this is an ANC spotter. I want you to have a look at it. This is showing you very characteristic. Look at this particular fetus. How does it look like? It looks really scary. It looks as if something is peeping down, an alien sort of a stuff. The entire face is triangular. It looks just like Vicks. You must have eaten Vicks. It looks triangular. And here also, this particular alien is peeping at you. You can see the two eyes of the alien, and you don't see that convex appearance of the fetal brain as you can see here. So what is wrong with this? Can you tell me? No, that's not a Mickey Mouse sign. So what do you see here? Now this sign is a very characteristic sign of anencephaly, and this sign is called by the name of frog's eye appearance. Now why I want you to know about this sign? Because anencephaly is actually the anomaly which can be picked at earliest. It can be picked as early as 10 to 11 weeks of gestation. I hope it's going to be clear. Now all of you are going to be easily identifying anencephaly. Just look for the fetal brain or fetal head. If it looks just like a Vicks, a triangular Vicks shaped appearance, you're dealing with anencephaly. Now a quick information about the mammography. So in mammography we have two views. Tell me, what are the two views? The two views are craniocaudal and mediolateral oblique. So examiner can give you a question and ask you to identify which of the view is this. Case number 1, case number 2. Again, both of them are from the same patient, two different images. Which of the following is craniocaudal view? Tell me. 1 or 2? I'm waiting. And how to identify it, how to remember it. Anyone? Sakshi, I'm waiting for your answer. You answered almost everything correct till now. Tell me, 1 is craniocaudal or it is mediolateral oblique? Take your time. I'm waiting. So the easiest way to remember this, guys, is just look at the shape of the breast. If it is going to be C like this, you see, it is a C-shaped appearance of the breast. So when you see a C-shaped appearance of the breast, it is a craniocaudal view. In this case, it's not C. See, it is not looking like C, but here it is looking like C. So the other view is mediolateral oblique view. So this is about mammographic views. Now, how do we identify, localize the lesion? So you can see that there is a lesion here, which is appearing some radio-opaque structure. And if we want to look at where is it lying, we just have to draw a line from the nipple which passes posterior to like this, perpendicular. In fact, it is curved one. The correct way is you measure it with this one. Okay. And on a mediolateral oblique, you draw a nipple line starting from nipple up to the lower part of the pectoralis muscle. So anything above it is outer, anything below it is inner. Anything above it is superior, this is inferior. So this is lying in the inner and the upper quadrant. I think it's going to be clear to you. How do we localize? Obviously, this question is unlikely to be asked, but you need to know this. Now, few important questions that can be asked from mammography. What is the age that we begin our screening mammography from? So, for individuals who are having a very high risk, like who are BRCA1 or 2 positive or with chest wall radiation, you start at 25 years. But 25 years, you can't do a mammo. You first do a breast MRI. From 30 years, you start in mammo. For patients who are having first degree relatives with breast cancer, just add 5 years to it, 35 years. For patients who are having average risk, who are not having either chest wall radiation, no BRCA, and who are not having any first degree relative, just add 5 more years, it's 40 years. Is it correct? This is again a very important question that can be asked. What is the time that we begin our mammography from? So I hope this is going to be clear with you. If it's clear with you, let's move on to our next slide about localizing the lesions, which we've already talked about. This is the lesion that we localized before, so I'm not going to go into the details here. Now we'll be talking about the important previous year questions. Now we've discussed about this topic in entirety. So tell me the answer. Which are the two cystic structures which form the double bleb sign in early pregnancy? Any one of you? What are the two cystic structures? This is a double bleb sign which is seen around 5 to 6 weeks of gestation. What are the two structures? We've discussed this before. Is it a heterotopic pregnancy? It is amnion or yolk sac? Is it the gestational sacs, or is it the amniotic sac and the chorionic sac? A, B, C, D. Anybody? I'm waiting. Where's your energy gone? Yeah, KK has finally come up with the answer. Perfect. You're correct. That's the B answer. Next one. What is the best time to assess chorionicity and amnionicity? We just talked about it. So I hope that you'll pick it correctly. The answer here is A, B, C, or D. Fine. Again, KK, I'm expecting an answer from you again. Where are the other gone? Sakshi, where are you gone? You're being missed. Is it first, second, third trimester or peripartum? Obviously, peripartum cannot be the one. Yes, KK, that's first trimester. So I think you're getting it correct. Now we've completed our first set part, that is the women's imaging. Now we'll be talking about GI radiology. So this was a question that was asked, and many a times this question has been asked in one way or the other. That is a question on bowel obstruction. A 64-year-old male patient presents with abdominal pain, distension, non-passage of stools for 3 days. So according to the clinical history, you're sure that it is obstruction. The examiner doesn't want to know that. Examiner wants to know what are the following things that are corrected. There is a dilated bowel loop with visible obstructions. Patient is having bilious vomiting. Patient is having dilated bowel loops with flatulence and increased bowel sounds, or dilated bowel loops with plica circularis. Obviously, the first two options, B and C options are out. Bilious vomiting, we don't expect in this type of bowel obstruction. And dilated bowel loops with flatulence and increased bowel sounds, examiner is contradicting himself what he said. So we can easily eliminate the two options. Now we are left with A and D, that is dilated gut loops with plica circularis or obstructions. Now tell me, first of all, let's do a quick image dissection. What do we see here? We can see a dilated loop of gut here. Jamula says it's D. This is dilated loop of gut. So where is it located? Is it central or is it peripheral? If I ask you what is the gut loop, does it look like a large gut loop or does it look like a small gut loop? So ever since we've been kids, like 9th and 10th class, we've learned about the diagram of the human digestive system in which the large gut is always peripherally placed and small bowel loops are placed centrally. Where do you think is this loop placed? Is it central or peripheral? It is central or peripheral. KK, I know you're correct, but let us discuss why you're correct. So it is obviously peripheral gut loop. So it is going to be a large gut loop. Now, if it's a large gut loop, we are just left with an option of plica circularis or ostration. So tell me, where do you find ostration? You find ostration large gut or you find it in the small gut? We find it in the large gut. Plica circularis are something which we call as volvuli conventis. The same thing is like volvuli conventis. They are interchangeably used terms. And where do you find volvuli conventis? In jejunum. The name itself says circular. It means they're going to be complete circles. They're going to be complete rings, while ostrations are incomplete. So since this is a large gut obstruction, we can see peripherally dilated gut loops. We can see ostrations within the gut loops. The answer is A. If you've not understood this, let us go ahead and look at another examples. What do you see here? I'm showing you two different views. This is image number 1. This is image number 2. Now you tell me which of the following is showing large gut. A is large gut or B is large gut? 2 is large gut. Which of the following is a large gut obstruction? Which is peripheral, which is central? This is what the examiner is going to give you now. One is peripheral, one is large gut, or one is small gut. So again, I think you can just draw it. It is just like this. It is located all peripherally. The same diagram that we've learned of the digestive system since we were kids. So this is a classical hallmark of a large gut obstruction where you can look at multiple ostrations which are incomplete. Remember, ostrations are incomplete. And in this second case, what we're looking at, again, we can look at multiple gas-filled loops of gut. And if I just magnify it, you can see that there are concentric rings all throughout. So this is a classical appearance of small gut obstruction. Yes, Jamula, now you're correct. That's a large gut and this is a small gut obstruction. And this volvuli conventis or plica circularis that you're seeing are classical hallmarks of dilated jejunum. By now, I hope you will never commit a mistake in identifying jejunal and large gut obstruction. Always do. When it is located peripherally, it is going to be large gut. And why ostrations are incomplete? Because stool is all formed. It is solid stool. If God would make a complete circle, complete mucosal fold in the large gut, then what will happen? Everybody will die of constipation because the fecal material will not move out of the concentric obstructions which are there. KK, you're correct. That's a large gut obstruction. Second is the small gut obstruction. So I think this point was clear. Now, three different images, three different signs of small bowel obstruction. First sign, what you can see, multiple air fluid levels. So multiple air fluid levels, when there are more than 3 air fluid levels, more than 2.5 centimeters, they are pathological. Here also you can see multiple air fluid levels. But here you don't see any air fluid levels. What do you see here? You can see multiple small air-filled loops of gut, one over the other. So now I want you to tell me the signs that are associated with case number 1 and case number 3. Only these two are having signs. This is nothing but this is just small gut obstruction. What are the signs? First of all, is it a large gut or a small gut obstruction? Where are the gut loops located? They are located in the center. So now you're going to be sure. Now I don't think anybody of you will make a mistake of calling it a large gut obstruction. It is a small gut obstruction. Now I want you to tell me the signs. Anybody? I know that's a bit difficult. I'll let you know I'll tell you these signs. You just have to remember them. Step ladder sign. Why it's a step ladder? You can see all these what you call as air fluid levels in a step ladder fashion. And this sign is called by the name of string of beads sign. Now you can ask me, sir, why is it representing small gut obstruction? Here we don't find any dilated loops of gut. My dear, there are dilated loops of gut. This entire gut loop is dilated, but it contains fluid and it contains some amount of air. So fluid is resting here, air is rising on the non-dependent part, and this is the reason why we get a string of beads appearance. So these two signs you need to remember, string of beads appearance and step ladder pattern. Now, before we complete it, what is the investigation of choice for suspected small bowel obstruction? We need to do a CT abdomen. We need to do a CT abdomen because on CT abdomen, we can actually find the cause of obstruction. There is a very important sign which we can see on CT abdomen, which is, I know it's a bit difficult. That is a small bowel feces sign. And we can actually also tell the site of obstruction. The zone of transition can also be seen on CT. So this is all what you need to remember. Management has to be, you have to put the Ryle's tube in and you have to ask the patient to admit the patient. You have to give him IV fluids, resuscitate him. And this is how majority of the obstructions are going to be dealt with because majority of them are adhesive bowel obstructions. Now let's come to the single most important image from the point of view of your exams. What do you see here? Tell me. A young male who's taking a lot of aspirin complained of sudden severe abdominal pain with rigidity, tenderness everywhere. What is the diagnosis? Tell me the diagnosis here. It's the easiest question that can be asked to you. This is the X-ray chest PA erect view. Anybody? What is this case representing? The history is that of a patient who was on chronic analgesic abuse with pain abdomen. Tell me. I think this is the easiest one. I'm waiting for your responses. I will not go ahead until somebody gives me this answer because this is expected from everybody of you. And this is the second image. Now, this second image, I'll tell you, this is a radiograph of the same pathology which has been taken on a supine view. This is a supine view. KK Jamula, what is the diagnosis? Come on, fast. I want everybody of you to make the diagnosis. This is a very important exam question. No answers. Where's the Josh gone, guys? Where's the enthusiasm? Go and grab your cup of black coffee or something. This session is going to last long. It's going to be high on energy. Still no answers. Oh, this is really depressing. This is perforation peritonitis. Easiest thing to be picked on. Why it's perforation peritonitis? Tell me. Because we can see air under the diaphragm. Once you see air under the diaphragm, you're sure that this is a case of perforation peritonitis. The investigation of choice. If somebody asks you what is the investigation of choice, investigation of choice in perforation peritonitis is CT abdomen. Whenever there is going to be air in question, the investigation of choice is going to be CT abdomen. What is the best radiograph if somebody asks you? Best X-ray? The best X-ray is this one. Chest X-ray, PA view in erect posture. But for patients who cannot stand up, patients who are lying supine, for them you can do a chest X-ray decubitus view. That's left lateral decubitus view with a horizontal beam. So the best radiograph is obviously X-ray chest PA erect view, but obviously the second best X-ray somebody asks you is going to be the left lateral decubitus with horizontal beam. Now, what is the management of perforation peritonitis? Many a times a question has been asked. Management is first give IV fluids, then resuscitate, then you take the patient directly for surgery. In these patients, let me take it directly to surgery. These patients, if you diagnose a case of perforation peritonitis on a radiograph, you don't need to do CT. Only in those cases which you don't, where you don't diagnose it on radiograph, you need to do further imaging. What are the signs? N number of signs. Whenever air comes and dissects into the peritoneal cavity, all the organs of the body are going to be showing it brightly. I mean, you can see the sharp interfaces based on the theory of radiographic density. So you will have the liver edge sign, you will have the GB edge sign, you can also have the Rigler's double bowel sign. That is, bowel wall would be seen. So that is called as double bowel wall sign. And sometimes air can get inspissated into the HRP, giving rise to what we call as Doge's cap sign. Although they are not really important clinically, but this is what you should be aware of. Sometimes can be asked because perforation peritonitis is a very, very important topic. Now, let's look at some of the key images which can come directly as spotters. Case number 1, I'll give you the history. It's a patient who's a child, 3 to 6 weeks of age, coming to you with projectile vomiting, looks emaciated, has a lot of electrolyte disturbances, and there is an olive-shaped mass which is felt per abdomen. So what is your diagnosis? Come on, tell me, what is the diagnosis in case number 1? In fact, I've highlighted pylorus also here. So the diagnosis in this case is CHPS, congenital hypertrophic pyloric stenosis. And this is the barium study. Perfect KK, that's CHPS. In barium study, because the pylorus gets narrowed, you can get a lot of signs. Like, no, that's not trichobezoar. How can trichobezoar occur at 3 to 6 weeks of gestation? In 3 to 6 weeks, you don't have trichobezoar. It's a child. In fact, it's a neonate. So all these signs that you see here occur because of thinning of the pyloric canal. So the common signs that we talk about are string sign, caterpillar sign. Then we have some other signs like this is a mushroom shaped appearance of the duodenum. So you can have a mushroom sign. There is another sign called as tit sign, beak sign, but I really don't want you to remember everything. You just want to remember string sign, caterpillar sign, and mushroom sign. And in the relevant clinical history, if the examiner is giving you this, then remember the diagnosis is CHPS. On an X-ray, you're going to get a single bubble. Coming on to case number 2. Now, this is a very, very important spotter. What do we see here? We can see a patient who's a neonate presenting on day 1 of birth with increased aspirate and vomiting. And when an X-ray was done, you see these 2 bubbles. This is the antenatal ultrasound image. Again, you can see 2 bubbles here. What is the diagnosis? Come on, I'm waiting. 2 bubbles, double, D for something else. Anyone? What is it? It is the double bubble sign. What is the disease which is associated with double bubble sign? D for Down syndrome. This is what you need to remember from this particular radiograph. Coming on to third case. Now, this is a very important case. Many a times it has been asked. This is going to be a child between 8 to 12 months of age coming to you with bleeding per rectum, with red currant jelly stools, and you can palpate something in the right upper quadrant. What is the diagnosis? This is the ultrasound image. We can see the classical target sign. Yes, perfect. You're correct, KK. That's duodenal atresia. What is this thing that we're looking at? The target sign. Patient coming to you with something bleeding per rectum. Jabula, yes, you're correct. You're correct. That's duodenal atresia. What are we looking at here? Waiting for your responses. And what is barium got to do with this particular condition? So this is a barium study because we can see an X-ray and we can see all this radio opaque barium around. So what are we looking at? Come on, fast. It is into. The name itself suggests into means something has got into something. So that is intussusception. And for intussusception, we can get these 2 signs. While we are reducing the intussusception, we can either get a claw sign or we can get this coiled spring appearance. Coiled spring appearance. The question that is going to be asked, KK, you're correct. You bang on. You're actually hitting all of them correct. I guess you're going to get complete on radiology. So you should be a radiologist ideally. You take radiology, KK. So what is the diagnosis? Diagnosis we all talked about. What's the question that the examiner is going to ask you? Is a gold standard investigation. Tell me. When is an investigation called a gold standard investigation? When it is not only diagnostic, but it is therapeutic. So what is therapeutic? What is a treatment in case of intussusception? You're perfectly correct, KK. It's associated with rotavirus vaccine as well. So the treatment that is given in this case is either a pneumatic reduction or a barium reduction. You can do it, or you can also do a hydrostatic. Means you're going to push out anything that you find, air, barium fluid inside the large gut, so that this creates pressure and this opens up on its own. So this is the reason gold standard investigation again is going to be barium enema, because it is not only diagnostic but it is also therapeutic. I think this is going to be clear. Let's come on to our next set of images. All of these are very important images. Again, barium studies. What do we see? In the first case, examiner will give you a hint: an elderly male, a smoker, alcoholic, coming with dysphagia, weight loss. What do we see? We can see that there is irregular narrowing of the esophagus in the mid-esophageal vagal region. There is a significant hold up. The upper esophagus is dilated. So, dysphagia is more to solids. Diagnosis: CA esophagus. What is the classical deformity that we see? The classical deformity that we see, or sign that we see, is the red tail appearance of esophagus. Now, the question that the examiner is going to ask you is, what is the investigation of choice for T staging or N staging? You're correct, KK, that's esophageal carcinoma. So T and N staging, what is the best modality? Because we have to look at the mucosa. T staging is for mucosal basis. So can we look at the mucosa on CT or MRI or something else? No, we can look at it only when we're looking at the mucosa from the inside. So the best investigation for T and N staging is an endoscopic ultrasound, while for overall PET-CT, overall staging of the cancer, it is definitely going to be PET-CT. PET-CT is for overall staging of the tumor. Now, case number 2. Again, a very, very commonly asked question. I want you to tell me, what are we looking at? What is this? What are we looking at? We can see a dilated esophagus, and this esophagus is showing narrowing at the level of GE junction. Somebody's come up with endoscopy. Yes, KK. It is not endoscopy USG, it's endoscopic USG. You're correct with it. So this is the rat tail appearance of esophagus. Sorry, this is the bird beak appearance of esophagus. Where do we get bird beak? Come on. Where do we get bird beak esophagus? I think you should all get a Red Bull for yourself, or get a black coffee. Nowadays, black coffee is in fashion. Everybody is drinking black coffee. Only KK is the one who's interested. Perfect, KK. You're correct again. That's achalasia cardia. And what the type of pathology achalasia cardia is? It is a mechanical pathology. Do you have a tumor in achalasia, or it is a motility disorder? It is a motility disorder. There is no tumor. So M for motility, M for manometry. All motility disorders, investigation of choice is going to be manometry. So in achalasia also, investigation of choice is manometry. The examiner is going to give you a hint of dysphagia more to liquids as compared to solids. Third case, an elderly female coming to you with dysphagia, halitosis, regurgitation. Again, you can see a contrast filled outpouching. I think the answer is going to be clear. Zenker's diverticulum. What are the important questions that are asked? Where is it located? It is located posterolaterally at the level of C5, C6, between thyropharynges and cricopharynges. Nothing else is going to be asked. Only these are the important ones that are going to be asked. This one, case number 4. Tell me what is the diagnosis. Then I'll go to case number 5. Case number 5, I'll give you a hint. This is a patient who's coming to you with dysphagia, iron deficiency, anemia, glossitis. What is the diagnosis? First of all, case number 4. What is the appearance? Appearance is a corkscrew. So this esophagus has a corkscrew appearance. Answer is diffuse esophageal spasm. And it is also a motility disorder because esophagus is moving differently. Investigation of choice is again manometry. Now let's come to 5, the one that I have asked. What is the diagnosis? Patient with dysphagia with other features like glossitis and iron deficiency anemia. We are dealing with a case of Plummer-Vinson syndrome. And what do we look at? What are we finding? We can find a web which is rising from the anterior wall of the esophagus. That's located in the cervical esophagus. So I hope this part is going to be correct. If it's correct, if it is done, let's go to the next one. What are we looking at? We're looking at 2 different volvulus. Case number 1 is showing you what volvulus? Again, this is the question that is most likely going to be asked. This is a sigmoid volvulus. And why it is a sigmoid? Because it is showing the typical coffee bean appearance. Sigmoid is seen in elderly psychiatric patients. The classical signs are coffee bean sign. Any other sign? We also have omega sign. We can also have a bent tire tube because this just looks like a tire tube. Look at it. If you remember, if you must have ridden cycle. I mean, I can remember it in my childhood days. Whenever there was going to be a puncture and we would go to person to repair the punctures. Now, he'll take the tire tube out and he would deflate it and inflate it and make it round. Then it would make this type of a shape. This is the reason why this bent tire tube sign has been given. If you see carefully, there are no hostrations. So there will be no hostrations in this volvulus. Now let's have a look at the second one. Jamula, you're correct. That was diffuse esophageal spasm a while back. Here what we're looking at? Here we are looking at a dilated large gut loop, but this is just looking like an embryo. Tell me, what is this embryo sign? Where do we get it? It is seen in cecal volvulus. Cecal volvulus. Cecal volvulus is seen in usually younger patients, typically in pregnant females. And treatment here is surgery. While these patients can be taken up for endoscopic detorsion when they have sigmoid volvulus. I hope this is going to be clear. What is this sign? This is a sign of a barium study. You can see barium has been passed through rectum. So this is a barium enema, and you can see a bird type of an appearance. So that's a bird of prey sign that is seen with sigmoid volvulus. Not very important to remember. If you can remember, well and good. If you can't, no, that's not Spalding sign. We've talked about Spalding sign already, Dr. Dhanalakshmi. Now, three spotters from large gut. Case number 1, 2, 3. What do we see in case number 1? Multiple outpouchings from large gut. Answer, diverticulosis. Perfect, diverticulosis. Investigation of choice for diverticulitis. Now the question has changed. It's not diverticulosis but diverticulitis. Will you give barium in diverticulitis? Can we give barium? No, we can't. If we push in barium in a patient with diverticulitis and he has got a ruptured small diverticulum, then the barium is going to spill over everywhere inside the peritoneal cavity, causing a significant peritonitis. So barium is contraindicated in all sorts of peritonitis, fistulas, leaks, KK. You're correct. We cannot give barium. So investigation of choice has got to be a CT scan. What is this second image showing you? Pain in abdomen, complaining of bleeding per rectum, known patient of some heart disease. What do we see? A dilated colon with a classical thumbprint appearance. What is the diagnosis? Tell me the diagnosis. KK is correct. That's CT. Thumbprint. What is the diagnosis? A cardiac patient and a dilated large gut. When do we get thumbprinting? Something causing eye ischemia. Any idea? That is ischemic colitis. Ischemic colitis. I hope you're going to remember this now. Now let's have a look at case number 3. This one I want you to tell me. I mean, this was a tough one, perhaps, but this is not a tough one. This has been asked previously in the exam. A patient who is an elderly patient coming to you with bleeding per rectum, with iron deficiency anemia. You do a barium enema to look for the cause of this particular pathology, and you find this type of a lesion. What is the answer? What is the diagnosis? Yes, that is apple core lesion. And where do we find an apple core lesion? We find it in cases of carcinoma colon. So these are the 3 important spotters that you need to remember. Next one, let's talk about FAST. FAST is so important that even its full form has been asked in the exam. So what does it stand for? Focused assessment. This is the reason I'm writing it in full. With sonography in trauma. So what do we do in FAST? In FAST, we do everything very fast. Dr. Roni, you're correct. That's carcinoma colon. We do everything fast. I mean, when a patient comes to you who's having trauma, he's having hypotension, you don't have the time to shift him to the CT or anything. What we have is an ultrasound machine. We ask the patient to lie down on a couch, and we place the probes at 4 positions. One in the right upper quadrant, the other is the left upper quadrant, one is the subxiphoid, that is the epigastric region, and the other is the suprapubic region. Why do we want to look at? Why do we want to? Yes, it is fast positive KK. Because we want to diagnose even minimal amount of fluid. So this image is showing what? It is a which is taken from hepatorenal pouch. That is the right upper quadrant. We can see the liver, we can see the kidney, and we can see this black colored thing. So what is black on ultrasound? Fluid is black on ultrasound. So this is a fast positive case. Now when we're talking about fast, there are 2 things that I want you to know about fast. First of all, how fast decides management. If a patient is fast positive, then the management will depend upon its hemodynamically stable or unstable. If he is stable, what you can do? Will you ask the patient directly get into surgical hands? No. We'll ask the patient to get a CT done to see whether the patient can be managed conservatively or not. The next thing is CT. But if the patient is unstable, if his blood pressure falls down to less than 50, millimeter of mercury systolic pressure. Can you ask a patient to go to CT room or to lie down anywhere? No. In those cases, you have to ask the patient to directly get a surgery done. So this is how fast decides management. When you talk about fast, there's another thing which is called as E-fast, where we look at the lung fields also. We look at the lung fields here as well as on either side to look for pneumothorax and hemothorax. So this is all what you need to do, need to know about fast. Fast is one thing which is used for screening in cases of trauma. It is done by ultrasound and is done to look for intraperitoneal fluid. Now this fluid is lying inside the peritoneal cavity. This is the reason why whenever there is a retroperitoneal pathology, fast is not as good as it is in cases of intraperitoneal pathology. Now let's have a look at few of the important questions. Now we've discussed this thoroughly. I want you to tell me what is the answer. What do you look at? 80-year-old female, scoliotic deformity, elderly female, moribund female with abdominal distension. What is this radiograph representing? A previous year question. We've discussed it in a big thorough manner. Cecal volvulus, fecolith, sigmoid volvulus or small bowel obstruction. Come on, A, B, C or D. I want you to give this answer. I mean, this is unpardonable if you don't tell this. It is sigmoid volvulus. I think it's going to be covered with it. Next, USG of fast is least useful in retroperitoneal hematoma, pneumothorax, renal injury or pericardial effusion. I've just talked about it in retroperitoneal hematoma as well as in renal injury, because kidneys are also retroperitoneal structures. But if you have to choose one option, that's going to be a retroperitoneal hematoma. Okay, that's correct. You're right. That was C, and the answer to this is retroperitoneal hematoma. Dr. Dhanalakshmi Enenkifili, I think you're looking at our previous images right now. Next one. What is the least useful investigation for this? Manometry, obviously investigation of choice. GI endoscopy, definitely. Barium solo, indefinitely. 24-hour pH monitoring. This is achalasia cardia. Where do we do 24-hour pH monitoring? In cases of gastroesophageal reflux disease, because we want to look at acid in the esophagus. So for that, obviously this makes sense, but for achalasia, no sense. In E-fast, we just talked about it. We want to look at thoracic cavity. It's going to be easy. KK, you bang on. I think you're going to get 100 on 100 in radiology. Last but not the least, this is one of the very important questions on perforation. What are we going to do in a case where who is expected of having perforation? We don't need to waste any time with ultrasound. We're going to give him IV fluids. We are going to do an exploratory laparotomy. We cannot do an elective surgery or a conservative management in this case. So the answer in this case is going to be 2 and 3 only. I think of you is going to get it correct. Perfect. Now we'll talk about hepatic radiology. The most important image that is asked is differentiation between an MRCP and an ERCP. So how you differentiate it? How to differentiate ERCP from MRCP? Is this MRCP or is this MRCP? I mean, image A or image B? MRCP is an investigation done in MRI, that is magnetic resonance cholangiopancreatography. And do we look at bones on MRI? We've talked about this a number of times. Bones will be black on MRI. Look at this image. Look at these bones. They are white. So it cannot be MRCP. Secondly, what is this large structure which is radio opaque? Is an ERCP cannula. Do you see any cannula here? No, there's no cannula here. So the best way to judge an image as MRCP or ERCP is you have to look at the cannula. If you look at the cannula, it is ERCP. If there is no cannula, then this is MRCP. A few important questions that are asked. What is the investigation of choice for looking at biliary pathologies or gallbladder stones, or in fact, not the gallbladder stones, but the stones in the CBD. So that's going to be MRCP because it is a non-invasive test. You just go inside the MRI machine, you just sit, the MRI machine is going to do its work and it's all done. ERCP on the other hand is invasive. What you need to do is you need to get an endoscope inside your body, and then that endoscope is going to hook inside your ampulla, and then you're going to pass on contrast inside your biliary tree, and this is again going to be done under radiation. So ERCP will have a lot of potential hazards. So ERCP can never be the investigation of choice, but gold standard is going to be ERCP because it can treat the patients as well. How does it treat the patient? I want you to have a look at both these images. First of all, diagnose. What is the pathology showing? What is this image showing you? It is an MRCP image. Do you see any pathology? Can you see this black colored or signal void in the lumen of CBD? So what does it represent? A previous year question, that is a CBD calculus, a classical case of choledocholithiasis. And what do we see in the second image with an ERCP cannula? we can see multiple filling defects within the lumen of the CBD. So both are representing choledocholithiasis. But the difference is you can also see a stent inside the lumen. What the endoscopist can do, he can put the stent, he can crush the stones, he can remove it. So ERCP is therapeutic as well. And this is the reason why ERCP is the gold standard investigation. The negatives of the ERCP is you cannot, you have to use radiation and you'll have to use contrast study as well. One other important question is with biliary leaks. So the most sensitive investigation of bile leaks. Many times it happens that people operate gallbladder stones, they injure the CBD, and there are a lot of collections in the abdomen. So the initial investigation in cases who are suspected of having a biliary leak is going to be ultrasound to look for collections. You can't ask the patient to get a MRCP or ERCP done directly. But if the examiner asks you what is the most sensitive investigation to look at biliary leak, then for most sensitive is HIDA scan, because it can tell you the presence of leak. But if examiner twists the question, he says what is the most sensitive investigation to look at the site of leak? The site of leak is going to be judged by ERCP. I hope this is going to be complete, clear and etched into your brains. There's going to be no doubt about biliary leaks, about MRCP or ERCP. Now, previous year question, a bit unfair to ask from your side, but it has been asked, so I'll have to answer this. Talking about the liver segments. So whenever the examiner gives you an image of CT of a liver, you'll have to look at two things. First of all, can you look at the hepatic veins? So these three structures which are passing this way are the hepatic veins. And if you don't see the hepatic veins, but you're seeing a gallbladder, it means that the scan has been taken slightly lower from the abdominal cavity. So when we look at the hepatic veins, the most posterior one, the superior segment is 7, this is 8, and this middle hepatic vein divides the right and the left lobe of liver, so it has to be 4A, and this segment has got to be segment 2. If the same section is taken a bit below, then 7 will translate into 6, 8 will translate into 5, 4A will translate into 4B, and 2 will translate into 3. Now this lobe, which is seen just anterior to the anterior to the IVC, is the caudate lobe. I know it's a difficult question to be asked from your side, but since it has been asked previously, you just need to understand the basic anatomical landmarks. Now, let's look at some of the important focal hepatic lesions and what the examiner can ask you. Case number 1, an alcoholic male coming to you with severe pain in the epigastric region, increased TLC count, and coming to you with a palpable lump in the epigastric region. CT is done, and this is the CT image. What is it showing? Tell me. Second hint, I'll give you, this is the second case, a patient completely asymptomatic coming to you with no abnormality, an instantly detected lesion in liver, and this is the CT which is being done. So what do you find? Third case, another, a young female, 24 years of age, completely asymptomatic, coming to you with an ultrasound which shows a liver lesion, and you do a triple phase CT, and this is what you get. Tell me. Hi Vanda Gape. Good evening, good evening. So now I want you to tell me the answer. What is case number 1 representing? What is case number 2 representing? And what is case number 3 representing? Case number 1, fever, leukocytosis. This is the CT of liver. What is it? Anybody? And he's having a focal hepatic lesion. So you see that there is a lesion here which is black as compared to rest of the liver, and you can see some edema also. Based on the history of leukocytosis, alcoholism, can you make a diagnosis of a focal liver lesion? That's an abscess. That's a clear-cut abscess. Here what we are finding a peripheral nodular enhancement. You can see this lesion is showing peripheral hyperdensities. So it's a case of a hepatic hemangioma, which is rarely going to be asked. The only question that the examiner can ask you for hemangiomas is what is the most common hepatic lesion. So most common benign hepatic lesion is a hemangioma. Next, what is this lesion showing you? You can see that there is a lesion which is showing a central scar. What is the lesion seen in a young age female with a central scar? That is a FNH, focal nodular hyperplasia. And another very common question that is asked is, what is it going to show on sulfur colloid? So sulfur colloid scan is the one which is taken up by Kupffer cells. It is a hyperplasia. Hyperplasia means it will contain other cells also similar to that of the liver. So hyperplasia will also going to take up Kupffer cells. So sulfur colloid will be positive. Now let's change the question. The question would be a young female again like this coming to you with a focal hepatic lesion, but the history is that of OCPs, or a male is coming to you with anabolic steroids and there's a hepatic lesion, what is your answer going to be? Whenever you see this term OCPs, then in all practical purposes, examiner is going to ask you about hepatic adenoma. So this is how some twist of the word can change the answer. I hope this is going to be clear as far as images are concerned. Remember the keyword scar, central scar, FNH, fever, leukocytosis, sepsis, and if there are OCPs, that's anabolic steroids. This is another case. If the examiner comes gives you a question of a patient whose hepatitis B or C positive, AFP is raised, and a CT of the abdomen is done, which is showing a lesion which is enhancing in one phase. You can see that aorta is opacified, but slightly arterial phase, and the same lesion is appearing black. Black means bad. Bad means it is giving washout in the delayed phase. So what is this tumor? Hepatitis B, C positive, patient is cirrhotic. So the answer in this case is going to be, tell me what is the answer? I'm waiting for it. Yes, KK, perfect. That's going to be HCC. The keyword is going to be AFP and washout on the portal phase. Now, different images, different faces, same lesion. Anybody? This is the easiest spotter that somebody can give you. Here, what you're seeing multiple septae inside the liver lesion. You can see some membrane-like which is hanging on around, floating inside the liver lesion. Here, you can see a cobweb sort of an appearance. Here you can see a complete calcified lesion, subperipheral calcification. Diagnosis, it is a cyst. Perfect starters, that's a hydrated cyst. You can either get a calcified type of appearance, you can either get a double wall sign, you can get this cobweb sign, you can see this water lily sign, any type of sign can be seen in this case. And the terminal stage is when the entire cyst gets calcified. And yes, you're correct, there all of them are in the right lobe except for this one which is located in the left lobe, and this one is also partially in the left lobe. So this is what you need to remember. The classification which is given is the Garbi classification. You must have studied that with surgery, so I'm not going to go ahead with it. Now, some of the most important spotters from gallbladder. Tell me what is case number 1 showing, 2 showing, 3 showing, and 4 showing. Anyone? Perfect, Dr. Abhirami, that's hydrated cyst. You got it correct. Now I want you to tell me what is this. This is gallbladder. This is ultrasound image. Now every image is showing you something different. I want you to tell me what is the difference. Case number 1. You should look at the gallbladder. It seems as if there is some raindrops showering all throughout the wall of the gallbladder. You can typically see that there is some raindrop type of an appearance. You can also call this as comet tail appearance because these are just comets which are showing their shadows. So stardust says 4th is posterior acoustic shadowing. Perfect. You're correct. That's posterior shadowing. And what is the thing which is showing shadow? A, somebody says polyp. Stardust, no. A is not polyp. A is showing you this raindrop type of an comet tail appearance. What is this? If A is polyp, then what is this thing? What is this thing which is hanging on from the wall? This is hanging from the non-dependent wall. It means it is attached to it. While this thing is lying on the dependent wall. It means it's gravity dependent. So this has got to be a stone. This has got to be a polyp. 3 is the polyp. Perfect. You're correct, Stardust. 3 is a polyp. What is case number 1? What is this comet tail? As if some comets are rising. That is adenomyomatosis. Adenomyomatosis. Stardust is correct. 4th is stone. Now this is a previous year question. What is this thing? This thing which is arising from the gallbladder fundus. It's just looking like a cap. A hint for you. What is this cap which arises from the tip fundus of the gallbladder? What is it? Come on. Hey Anil, you're correct. That's adenomyomatosis. What is this cap? That is called by the name of Phrygian cap. So if you see any cap-like structure arising from the top, from the fundus of the gallbladder, that is Phrygian cap. Now let's look at a few of the questions. Stardust, you bang on. Correct. Second is Phrygian cap. Case, this is the question that has been asked previously. The highlighted liver segment. So what are we seeing here? It is a segment which is taken from superior part. Anil, no, that's not acute cholecystitis. This is the gallbladder stone, but there is no cholecystitis here. So this is segment 7 as we just talked about. So this is going to be segment 8. I hope this is going to be correct. This is going to be crystal clear with you. What do we see here? We've discussed this before as well, and almost everybody of you answered it correctly. This is a classical hydrated cyst. And in cases of hydrated cyst, we don't do a biopsy because it can trigger an immunological response. Next one. What if the following is not an indication of ERCP? Periapillary mass, we want to look at it. We want to take a biopsy. Unexplained jaundice, we want to rule out a small stone which is located causing obstruction to the CBD. In recurrent pancreatitis, again, we want to look at any abnormal pancreatic ductal pathology. We need to do an ERCP. But without choledocholitis, what are we going to do? If there is a patient who's coming to you with alcoholic pancreatitis, why would you do a ERCP? You already know that's an alcoholic pancreatitis, so this is out of question. Last, biliary leak question. A biliary leak is suspected. What is the next best investigation? So again, this is a question which is very difficult to answer. Now, first investigation is going to be done in ultrasound, but ultrasound has been done and we now know that there are collections. So MRCP, ERCP or HIDA, you can do any of them, but if the next best investigation is suggested, then you would like to do HIDA, which is the most sensitive investigation. So the question is, sir, so we first do MRCP, and if there is a stone, we go for HIDA. We don't go for HIDA directly. Why do we need to do for HIDA in cases of MRCP? In this question, if you're talking about, okay, so we don't do an MRCP directly, Stardust. If we do an MRCP for a suspected gallbladder stone or a CBD stone and we pick that stone, there's no need for HIDA. HIDA is done conventionally for acute cholecystitis when we are not able to visualize the gallbladder. But nowadays, the investigation of choice for cholecystitis also is not HIDA, it is ultrasound, because again, it's a non-invasive investigation. Now let's start with our CVS radiology. The first thing, it is these four structures that you need to tell me. Number 1, number 2, this is number 1, number 2, number 3, number 4. What are those? So for this, I have told you, there is a short form called as SAPDA. Some people told me SAPDA in some language means food that you eat. If you know what language that is, just write in the comment boxes below. But SAPDA, somebody told me that the term that we use for food in one of the local languages is called as SAPDA. So why SAPDA is important? Because SAPDA is representing S for SVC, A for ascending aorta, 3 for pulmonary trunk, and RA, that is SAPDA, DA, 4th for descending aorta. Your right starters, that's pulmonary arterial bifurcation. This is the right, this is the left pulmonary artery. I think it's going to be clear. Just remember this SAPDA, starting from right to left. We'll be talking about this later on. We'll be looking at different cases. Then this is the second image. What we are looking at? We are looking at heart. Why? Because this is air, this is air, this is a CT, and what is black on CT? Air. So we're looking at an organ where where the central organ is a soft tissue, and on either side we have air. Where in the body you have air on either side? That is chest. So this is the chest CT. This is heart. So what do we look at in heart? The examiner is going to ask you to identify the various compartments or various chambers in heart. So this is one chamber. You can see a wall. This is another chamber, highlighting with pink. This is another chamber. I'm highlighting with a different color. And this is our last chamber, which is most posterior. Now you have to tell me what is green. What is green chamber? What is this? The one which is lying just posterior to sternum, because this is anterior, this is posterior, this is right, this is left. So the thing which lies most anterior is the right ventricle. Most posterior, that is left atrium. We know this because we've talked about this in case of mitral stenosis. Posterior most is LA, perfect, Stardust. So this is right ventricle, this is left atrium. What are we left with? What is the thing which supplies blood to the right ventricle? From here to here. The chamber that supplies blood from right to right ventricle is the right atrium. And this thick walled chamber is going to be left ventricle. I hope everybody of you will be identifying it now. And this structure which is posterior most is the descending aorta. So after the anatomy, now let's have a look at few of the important spotters. Stardust, you are correct. That was right atrium. Look at this patient. A patient who's having hypertension, just 13 years of age, coming to you with radiofemoral delay, difference in the pressure in the upper limb and the lower limb. Can you make the diagnosis? In fact, I saw this patient only around 14 days back. She came for a renal Doppler and incidentally we picked up this thing. She was not willing to actually accept the diagnosis. We even did a CT angiography. Now, mind you, we are doing a CT aortography or angiography. So this is a hint for you. What is the diagnosis? I want you to look at the undersurface of the ribs. The ribs are showing scalloping. So this is called by the name of Rosler sign. Diagnosis is coarctation of aorta. And we have another sign. You can see that there is a 3 type. Very good, Stardust. There is a 3 appearance of the esophagus of the aorta. So this is 3 sign. What is this? So big heart. You can see the cardiac chamber silhouette as if somebody has put a lot of water inside the heart. Heart is now bulging. So what is the diagnosis? Diagnosis is pericardial effusion. What are the signs that we see in pericardial effusion? We see a water bag sign. We can see a flask shaped, perfect, a money bag sign or a money bag heart is also seen. And if we do a lateral radiograph, what are we going to get? You're going to get an Oreo cookie sign. Now, tamponade is basically a clinical diagnosis. Depending upon the quantity, we cannot call it whether it's a tamponade or not. If the patient is having raised JVP and the other signs, then we can call it tamponade. Investigation of choice. In case of pericardial effusion, investigation of choice. Whenever there is going to be fluid, investigation is going to be ultrasound. That's ultrasound. Now let's look at this image. What are we looking at? We're looking at a calcification all around the heart. The diagnosis of calcification around the heart is calcific pericarditis. And what is this particular sign called as? That is called as egg in cup appearance. I hope everybody of you are going to be clear with it. Now let's come to our next case set of images. All these images are showing you different stages of CHF. I don't want you to remember everything. I just want you to remember the important signs. This is the stage 1 of CHF between 13 to 18 millimeter. This is 18 to 25 millimeter mercury, and this is more than 25 millimeter mercury pressures. This is not which is important. This pulmonary capillary wedge pressure is not important. What are the signs? Here, what we are seeing here, we can see a dilated pulmonary trunk, but we can see this upper lobe diversion of pulmonary veins. What is this sign? This type of an appearance. Mustache. Do you remember something? Something like an inverted mustache, something like a stag antler, something like a thumbs up. Yes, that's a thumbs up sign, or you call it stag antler sign, or you can call it an inverted mustache sign. Sign is seen in stage 1 of CHF. What do you see here? We can see multiple parallel lines which are placed almost perpendicular to the lung surface. Something curling lines, curly here. What is these lines? And what are these lines seen in case of stage 2 of CHF? This is a classical curly B line, and this is something I want you to remember. This is something which has been asked many times. Last, what is going to happen? You're not treating the patient, you're giving all the fluids to the patient. His lung will explode, and this lung explosion would just look like a parahilar opacity, and this parahilar opacity is given a fancy name, bat wing pulmonary edema. So these are the 3 important images from the point of view of congestive cardiac failure I want you to remember. Now, I want you to make a diagnosis. I'll give you a hint. This is a patient who's had a pelvic surgery. Anil, you are correct. That's bad wing. Patient who's had a pelvic surgery. After pelvic surgery, severe chest pain coming to you with dyspnea also. And you do a CT pulmonary angiography, and this is what you find. What is the pathology? Now, we've already talked about SAPDA. Tell me, where is the problem lying in SAPDA here? It is in the SVC, aorta, pulmonary artery, or descending aorta. Type it. Type in your comment box. I'm waiting. SAPDA. This is the second image. Tell me what is the radiological sign that you can see in this image. Stardust is on fire. You're right. It is pulmonary embolism. But why are you saying it's left-sided? Here we can see a filling defect in the right pulmonary artery as well as in the left one. So it is a pulmonary embolism which is affecting both the pulmonary arteries. And you can see here again in the segmental arteries, there is a thrombus, but you can see some patent artery in the peripheral part. So this is a classical polo sign, polo mint sign that we see. And this is the radiograph which is showing this wedge-shaped infarct. There are n number of names which have been given. Fleischner sign, which refers to dilated pulmonary artery here. Palla sign, again descending pulmonary artery dilated. And we have another sign which is called as Wester mark. This is the one which I want to remember. Wester mark means the markings are going to be reduced in that area of thromboembolism, because obviously there's going to be less of perfusion. What is the investigation of choice? We've just talked about it. This is the same investigation that we've done. That is CT pulmonary angio. And what is the screening investigation? We don't have anything, so we do a D dimer. If D dimer is raised, then we do it. Yes, Stardust, you're correct. Now comes the most important slide for congenital cardiac diseases. What is this? What is this? What is this? Tell me. Case number 1, case number 2, 3. Keep on typing. 4 and 5. First of all, number 1. KK, you're correct. That's CTPA. Now we are on congenital heart diseases. So in the congenital heart diseases, perfect. That's TOF. You're correct. KK, you're correct. That's D dimer. Case number 2, Stardust. What is case number 2? Case number 3, case number 4. I want to tell at least the 3 ones. The third is TGA. Anil, you're correct. That's TOF. This is TGA. Yes, I agree with you. You're correct. What is case number 4? Anybody? So, okay, let's start into the ones which we've got. So, this is tetralogy of Fallot. Why? Because we can see a boot-shaped heart of Corinth Sabot. So, that's a boot-shaped heart or Corin Sabot, which occurs due to right ventricular hypertrophy. Perfect. Then 3, the shape of the heart is typically like an egg, and this type of an appearance is called as egg on side or egg on string appearance. So that is TGI. I agree with you. Perfect. Case number 2, it's not that difficult. Just use your eyes a bit. I won't say use your brains a bit, use your eyes a bit. How does it appear like? What is the shape of the heart? It's just like a box. B for box, and there is only one anomaly which is having a box in its name. No, this is not TAPVC. This is not TAPVC. B for box, the anomaly is having a B in its name. That is Ebstein's anomaly. Ebstein's anomaly. Perfect. Case number 4, a snowman appearance. S for snowman, S for supracardiac TAPVC. KK4, this 4 is supracardiac TAPVC. And this Ebstein's anomaly is also associated with Himalayan P waves, Wolff Parkinson White syndrome, and maternal lithium intake. 5th is a gooseneck type of an appearance, and this we find in endocardial cushion defects. This is a difficult one, but remember these 4 ones, you're going to probably get a question from the first 4 images. Next one, emergency, severe chest pain, hypertension, and what do you see? You see this intimal flap. The diagnosis, classically we can see this intimal flap in SAPDA, descending aorta. So this is a case of aortic dissection. And what is the two lumen? One is the true lumen, the other is the false lumen. What are the 2 different types of aortic dissection that you know? Starters, you're perfect, you're correct. We have Stanford classification A and B. Remember, when ascending aorta is going to be involved, that is going to be A. When ascending aorta is not going to be involved, beyond the left carotid vessels, it's B. So here we can see it is the distal part which is involved. So this is Stanford B. While here the ascending aorta is itself involved and it is extending all throughout. So it is Stanford A. We are not interested in rest of the aorta. The most important part is the ascending aorta. So aortic dissection. Now comes the investigation of choice. Tell me. Well, yes, Stardust has asked a good question. What is the investigation of choice? So again, here we're going to look at the patient. These patients are really very sick. So if the patient is stable, then what are you going to do? Then he can be shifted to the CT room. So we are going to do a CT angio. But if the patient is unstable, yes, you're correct, perfect, Stardust. We are going to do a transesophageal. Why we don't do a 2D echo? Because we want to look at this SAPDA, descending aorta. This is posterior and it is lying just adjoining the esophagus. So TEE is the best investigation. Next one. What do you see here? Another emergency. Patient coming to you with hypertension, with no pulsatile mass. You see this particular outpouching here. You see this outpouching here. You see this outpouching here. All of them represent aortic aneurysm. And this sign on Doppler is called as the yin-yang sign. Investigation of choice in aortic aneurysm, same. That's going to be same. That's going to be CT angiography. Risk of impending rupture. If you see this draped aorta or this crescentric thrombus, that is crescent sign or draped aorta signs are signs of impending rupture. So let's look at some of the questions. Diagnosis here, typical boot-shaped heart. The answer is tetralogy of Fallot. This is something which everybody of you would have got correct. Now, let's start our discussion on chest radiology. We'll be quickly going through some of the important spotters. Case number 1, 2, 3, 4. What is it representing? Case number 1, we can see that there is a patient coming to you with severe shortness of breath along with chest pain. What we see, we can see that the lung is collapsed and the entire chest is full of something air, but there are no bronchovascular markings. Diagnosis, case number 1. Case number 2, the same patient coming to you with chest pain along with a lot of disturbances in respiration. But now he is having engorged veins all over his neck and the patient is visibly looking dyspneic. He is having hypotension. Case number 3, same patient coming to you with same complaints as case number 2. And case number 4, patient coming to you with chest pain on left side, but there is a history of road traffic accident after which it is happening. So one is not a bulla. What do you see here? You can see that the lung is collapsed and we can see there is no bronchovascular markings. It's a classical case of pneumothorax and the lung is collapsed here. So we see this sign which is called as the visceral pleura sign. Stardust, you're correct. 4 is diaphragmatic injury. Tell me what is 2? 2 is, you can see a midline shift also. The mediastinum is shifted towards the contralateral side. So there is a pneumothorax because we can see the visceral pleura line. This entire part is now occupied by air, but there is a midline shift also. So the Body is in tension. Everybody is in tension. So this is tension pneumothorax. So tension pneumothorax, the question that is asked is management. In children, you don't have time. You can't ask the patients to go to a OT and get an ICD placed. So for them, what we do, the best thing we do is you have to put a needle thoracostomy. And where do you put the needle? You place it anywhere in the second intercostal space in the mid clavicular line. In children, it is the second intercostal space. While in adults, you have to place it in fifth intercostal space in mid axillary line. Here it is mid clavicular line. After this thing is done, you can ask the patient to go ahead and get a elective ICD placed. In this case, when the patient is not having tension, you can obviously ask the patient to get an ICD. So for this treatment is ICD. Here, again, what you're seeing air, but what you're seeing here is a blunted left CP angle. Yes, stardust. In both 1 and 2, we have visceral pleural line. Perfect. That is good. That is a sign of pneumothorax. It is a sign of tension pneumothorax also. Here we are finding a midline shift, but we are seeing a horizontal line. H for horizontal, H for hydropneumothorax. You've already answered. I won't go ahead. 4 is somebody is written as diaphragmatic injury. You are perfect. You're definitely correct. Why? Because stomach has herniated. This is the left side. And you can see that there is a convex border superiorly. If it would have been a horizontal border, I would have called it. Yes, KK, it's fifth intercostal space in adult. So I would have called it a hydropneumothorax. But since you can see a part of the diaphragm being placed superiorly and stomach is herniated into the thorax, the classical case of diaphragmatic injury. And in this case, you cannot put an ICD directly. Otherwise, you'll go and puncture the stomach. Now, another very characteristic sign that examiners are very fond of. So this is M mode sonography. M mode sonography, we look for the motion of the lung. So this is case number 1. This is case number 2. I'll tell you, one is normal, one is abnormal. What is abnormal? What do you see here? You can see a grainy appearance, and this grainy appearance is just looking like, all of you must have been to Goa, na? So I miss Goa anytime I come across this case and I talk about this. So you see all this grainy appearance. This is classically looking like a seashore. So this is the classical seashore sign. You're perfectly correct, Stardust. You're always correct. What is case number 1? You must have studied ECG. ECG is something like this, na, QRS complex. When a patient dies, this is a straight line. So when the motion of lung will die, you will all get a straight line like this, this. So this is a barcode sign. This is a barcode sign. And where we do get a barcode sign, we get it in case of pneumothorax. This is a classical seashore sign seen in normal individuals. And you can easily remember that only people who are normal can go to Goa or seashore. So that's a normal sign seen on M mode sonography. Case number 3. Now here we can see actually a transition between a barcode sign and a seashore sign. It means it is exactly here where the pneumothorax is starting. So it is called by the name of lung point sign, which is a very important and specific sign for pneumothorax on M mode sonography. Now look at these two images. Both of them are spotters. These are both CT images. I hope there's going to be no doubt about it. Now what do we see here? We can see that there is an area which is appearing abnormally white. And this is showing some lucencies also. So what is this sign when you see an area which is white? Why would an area of lung be white? Why does an area of lung appear white on an X-ray? Because of either consolidation or effusion. But here it is occurring inside the lung parenchyma. It doesn't look like an infusion, looks like an effusion. So what is one? What is this image? This image is representing perfect consolidation, and the sign that we see is, we can see some patent bronchi through it. So that sign is called as air bronchogram sign. Where we can't expect air bronchogram sign? In cases of extrapulmonary pathologies. Whenever there are bronchi, we'll have air bronchogram. The name itself says air bronchogram sign. So consolidation, collapse, you can have this air bronchogram sign, even in cases of the hyaline membrane disease. But in pneumothorax, bronchi cannot go in pneumothorax in pleural spaces, or it cannot go into mediastinal masses. So there you won't get it. Second case, you have answered perfectly correct. That is classical bronchiectasis, and this type of the sign is called as cluster of grape appearance. You can see this cystically dilated bronchi just looking like a cluster of grapes. A previously asked question. Now let's come to counting of ribs. How do we count the ribs? So the best way to count the ribs is to look at their orientation. First, palpate your ribs on your own. So you will see, when you palpate your ribs are more oblique anteriorly, and you will see your ribs are more horizontal posteriorly. So all these horizontal ribs that you are seeing, these are your posterior ribs that are not your anterior ribs. So how do we count them? We start from rib number 1. So this is rib number 1. This is rib number 2. Then this is rib number 3. And this is rib number 4. This is rib number 5. I'll count only this much for you. So this horizontal part is the posterior part. This oblique part is the anterior part of the rib. So if I ask you, if there is a fracture here, so can you tell me which rib is fractured here? Is it the anterior or is it the posterior? Is it right or is it left? Come on, type the answer. Which is the rib? Let me help you for that. So this is the first rib here. This is the second rib which is coming here. This is the third rib. This is fourth rib, fifth rib, sixth rib, and what is it? Can you tell me what is rib is this? Yes, that's the seventh rib. Now, if you have learned how to count ribs, I want you to have a look at this particular case. What is the diagnosis? There is something gone wrong with the ribs. I will tell you this. Come on, tell me what the answer is. Just look at both the sides and compare. There is one extra rib on one side. Anybody? So you see that there is an extra rib here. If you see an extra rib here, the diagnosis is cervical rib. Here also you can count the ribs. This is rib number 1. This is rib number 2. This is rib number 3. This is rib number 4. This is rib number 5, and so on. Stardust is correct. That's a cervical rib. Now, two important pathologies where we're going to make use of Silhouette sign. I want you to answer two questions. First of all, lobe of lung which is involved. Secondly, what is the pathology? So whenever the examiner is going to ask you about the lobe of the lung and you see an area of opacification, you will have to make use of the Silhouette sign. So tell me, which of the following lobes is involved? Where is the Silhouette occurring? First of all, look at this image. Is it collapse or is it consolidation? Yes, one is consolidation. You're right. Oh no, you're talking about the previous one. So here we are finding signs of volume loss also started. So this is a sign of volume loss. It means we are having collapse, while this is consolidation. And which is the area of heart which is silhouetted? It is the right cardiac border that we don't see. And if we don't see the right cardiac border, the pathology is in the right middle lobe. Next, classical spotters. A young child coming to you with severe neck pain, dysphagia, high-grade fever. Second one, a child coming to you with barking cough. I want you to tell me the diagnosis as well as the sign. Let me magnify this for you. What is it looking like? What is this area? This is the epiglottis, and this sign is the thumb sign. Diagnosis is epiglottitis, and it is caused by Haemophilus influenzae. You are correct. That was the middle lobe pathology. Here, what we are seeing is, yes, perfect starters. This is the steeple sign of croup called laryngotracheobronchitis, and it is one of those pathologies which can be cured on its own as well. Next, concept of foreign bodies. Whenever you see this O appearance, the foreign body is lying in the uso or esophagus, while if you see this T appearance, it is lying in the trachea. But the examiners are going to go one step ahead. These AIMS people have this habit of asking something else which is different. So what do you see here? You can see a foreign body which is having two concentric rings and it is having beveled margins. Compare both of them. So here, look at them. Look at this foreign body. It is not having two concentric rings, while this one is having a concentric ring. And it is also having beveled margins here, while this is having perfectly normal margins. So this is a button battery. This was the question that was asked. A button battery, and it has to be removed because it can release some alkaline substances and can lead to corrosive injury. Next one. The examiner is going to ask you a patient who is a chronic smoker coming to you with cough, hemoptysis, and now he's developed a new symptom, left-sided chest pain along with drooping of the eyes, Horner syndrome. So what is the diagnosis? You can see here that there is an area of opacity, but there is destruction of the rib. And here also we can see the destruction of the rib. What is the diagnosis? No, that is not tubular heart stardust. You're correct, that was button battery. This is not tubular heart. Look at it. We can see a mass lesion which is eroding through the ribs. Diagnosis is a Pancoast tumor. Pancoast tumor. And why I'm showing you this? Because investigation of choice in Pancoast tumor is MRI. While for all other lung malignancies, it is, you're correct, that's bronchogenic carcinoma. For all other malignancies, it is CT chest. Another important sign. What are you looking at here? We are looking at an S-shaped appearance. We can see collapse also because there is a mass sitting here. What is the diagnosis? What is the sign? Again, this is a golden sign. I'll give you gold for it. Golden S sign. Okay. I hope you're never going to forget these two signs. So the questions that are asked. A 60-year-old smoker coming to you with hemoptysis, negative for acid fast bacilli, so you know that you're talking about bronchogenic carcinoma. And I've talked to you about this. Bronchogenic carcinoma, investigation of choice is CT. Next one. A 10-year-old child presenting with mild intermittent abdominal pain. You see that there is opacity here. Now, this opacity here can represent anything. It can either represent a pneumonia also, but we can see the cardiac border is seen separate from it. Now we're left with two options. Either it's going to be a Morgagni or a hiatus hernia. It doesn't look like a lung abscess because history is not supportive. Secondly, a lung abscess is going to be seen as a cavity with air fluid levels. Bostel-like hernia is posterolateral, while this is occurring medially. So either it can be a hiatus hernia or it can be a Morgagni hernia. Hiatus hernia is usually retrosternal. It is somewhere here, but it is parasternal or paramedian. So answer in this case is Morgagni hernia. Next question, that's something which we have talked about in detail. It is a classical case of tension pneumothorax. So what are you going to do this? The answer is going to be B. First, you have to put an emergency treatment and then ask the patient to get a perfect treatment, or you can go to elective treatment later on. Now let's start about musculoskeletal system. The images representing the most important images, the most important pathology. What you see, the history that is going to be given to you is a patient who's a young male coming with backache, coming with morning stiffness, with some pathology in breathing as well. And the clinical clue is going to be HLA-B27 positive. So what are we looking at? We can see some shiny corners along the anterosuperior corner. So that's called as the shiny corner sign. And if this shiny corner gets eroded, you can see that there are some erosions here. This is going to be called as Romanus lesion. Now this is one of those conditions which is characterized by syndesmophyte formation, both anterior and posterior syndesmophytes, as you can see here. Later on there will be squaring of vertebra, your perfect KK, that's ankylosing spondylitis, and there will be a bamboo spine or poker spine, which you might already be knowing about. Then this is another way in which it can present. It can result in calcification of ligaments. So if there is going to be calcification of the interspinous ligament, it is going to be what? Yes, it is going to be called as a dagger sign. And if there is going to be calcification of the paraspinous ligaments, it would just look like a trolley track. So that if it is going to be only the paraspinous ligament, it is going to be a railroad sign. While if all the three are going to be involved, it is going to look like a trolley track. So that's going to be called as a trolley track sign. Finally, you can get this anterior and posterior syndesmophytes all throughout. And if the patient develops a fracture to the brittle spine, this fracture, I hope you know, that's called as a carrot stick fracture or a chalk stick fracture. Then, what is the first joint to be involved in ankylosing spondylitis? This is a different question I'm asking. What is the first joint? That is SI joint. And what is the investigation of choice for looking at the SI joint? That is MRI, and specifically its stir sequence. So this is all what you need to know about ankylosing spondylitis. Next one, pediatric cases. You see metaphyseal abnormalities, your correct status, that is MRI. And you can see some rosary bead type of an appearance here. You can see something gone wrong with the epiphysis. This is case number 2. So whenever you see anything wrong with the metaphysis like cupping, widening, fraying, you know you're dealing with rickets. And you can also find a ricketic rosary which is painless. It is going to be painless because there's going to be no hemorrhage in rickets. While in the second case, which is caused due to vitamin C deficiency, there's going to be hemorrhage everywhere. So this is going to be called as scurvy. It is going to be a painful disease, and all the white signs, that is white line of Frankel. There is a white rim around the epiphysis called as the Wimberger sign. Then if you just clean it up, you can see a zone of rarefaction, trauma-filled zone of rarefaction. These white colored bird like spurs, a white colored bird called as pelkan. So these are pelkin spurs. So all these findings can be seen in scurvy. Scurvy also causes bleeds. So these subperiosteal hemorrhages which become calcified are also seen in scurvy. You perfect, KK, you are doing it correct. Then skull appearances. Case number 1, 2, 3, 4. The skull is typically looking like a screw cut. Where do we get the screw cut skull? We get it in cases of all forms of hemolytic anemias. Another very important question can be asked. Remember this. If it is a thalassemia, it's hereditary spherocytosis, even in iron deficiency anemia, you can get it. What is this skull? Typically looking like a copper beaten appearance, silver beaten or copper beaten appearance. Where do you get it? You correct, Stardust, that's thalassemia. We get it in cases of raised ICT. What is this skull? A young child around 5 years of age coming to you with a palpable mass, and you find this geographical lytic lesion with B-weld margins, also with a button sequestrum. Button sequestrum. What is the diagnosis? It's EG, eosinophilic granuloma. Eosinophilic granuloma. Finally, last appearance. What do you see? See typical pepper pot type of an appearance. Multiple small lytic areas. Where do we get it? Hyperparathyroidism. And what is the cause of hyperparathyroidism? Most common cause? Parathyroid adenoma. Investigation of choice of parathyroid adenoma. It is technetium 99 system B. And if somebody asks you, SPECT is definitely a better investigation for it. Best investigation. What are the other signs that you get in hyperparathyroidism? You can also get a rugged jersey spine. You can get erosion of lamina dura. You can get subperiosteal resorption along the radial aspects of the digits. You can also get a tumor, which is a misnomer, brown tumor, a misnomer. Sir, in both multiple myeloma and LCH, yes, you can get in both them, but LCH usually presents a solitary lytic lesion. The localized form of LCH is eosinophilic granuloma, where you find this, and the age is going to be completely different. Multiple myeloma is seen above 40 years of age. 98% cases of multiple myeloma that have been reported so far are above 40 years of age, while LCH is a disease of infancy and childhood. LCH can affect multiple organs. It can affect spine also. Yes, KK, you're perfectly correct. The LCH is a disease of young age. You've already answered that. Next image, what do you see? You can see that there are multiple osteophytes in a flowing pattern of ossification along the anterior aspect of the cervical vertebra. Diagnosis. Case number 2, calcification along the posterior aspect of the vertebra. Diagnosis. Come on. This is, what is this? This is dish, not the one to eat, but diffuse idiopathic skeletal hyperostosis. More than 4 vertebra to be involved. Most common site for dish, thoracic spine. While what is this? This is the ossification of the posterior longitudinal ligament, also called by the name of Japanese disease. Japanese disease happens to the Japanese. And where is the most common site? Because dish is most common in thoracic spine, so it is going to be most common in cervical spine. I hope everybody of you gets it correct. If you're correct with it, let's move to our next set of images. The different vertebral body appearance. A sclerotic vertebral body. What it is called? Ivory vertebra. Ivory vertebra seen in Paget's, can be seen in lymphoma also. This biconvex vertebra, codfish, osteomalacia. What is this vertebra? Plain, papad, plana. In children, it is caused by LCH. In adults, it is caused by multiple myeloma. Case number 3, picture frame. P for picture frame, P for Paget's. This is the classical rugged jersey spine that I was talking about. This rugged jersey spine you can get in cases of hyperparathyroidism. Bullet shaped vertebra seen in achondroplasia. This is a beaked vertebra, middle beaking in cases of mucopolysaccharidosis. Morquio syndrome. I know it's difficult, but you need to remember. The ones that you need to really remember are this one. You need to remember about this one, which I'm going to talk about, this one and this one. Just keep a memory of these images in your mind. What is this? H-shaped vertebra. H. Where do you get H-shaped vertebra? H is seen in some anemia. Tell me. One anemia. I'm giving you a hint. S. It starts with S. Which anemia? HS. That is sickle cell anemia. H-shaped vertebra in sickle cell anemia. Now let's talk about lesion with many faces. That is what? What is it? A ground glass opacification, ground glass matrix, a woven bone type of an appearance with a Shepherd group deformity, or a sclerotic region with a Rind sign. Can you tell me the diagnosis? Must have studied this in cases of, studied with orthopedics. Stardust, what does SCA stand for? I didn't get you. Acha, sickle cell anemia, perfect, you're correct, you're correct. Now, where do you get this Rind sign? Or where all this appearance? Tell me. Again, this is a previously asked question. That is FD, fibrous dysplasia. And fibrous dysplasia is either monostotic or polyostotic. Polyostotic is associated with McCune-Albright syndrome and Mazza-Brod syndrome. Mazza-Brod syndrome is associated with atrial myxomas. Yes, Stardust, that's fibrous dysplasia. Well, McCune is associated with precocious puberty, polyostotic fibrous dysplasia, and cafe au lait spots. Next one, typical corduroy cloth appearance or a polka dot appearance. Answer is vertebral hemangioma. Then let's talk about this case. You can see an exostosis which is hanging. It is a case of osteochondroma. And the important thing about osteochondroma, it contains a cartilage cap, and cartilage cap should be less than 2 centimeters. If it becomes more than 2 centimeters, it is a marker of malignancy. Yes, you're right, it's hemangioma. And apart from that, if you find increased growth after skeletal maturity, any new scintigraphic evidence of activity, or if the patient complains of a soft tissue mass, these are all signs of development of malignancies in an osteochondroma. Sarcomatous differentiation to osteosarcoma and chondrosarcoma. And these are the important signs. You need to remember this because this has been previously asked as well. Now let's look at three important. Hi Rahul, how are you? Now let's talk about three important malignant tumors, important from the point of view of your exams. Case number 1, what do you see? Case number 2 and case number 3. Case number 2 we've already seen. This is just a revision. I mean, we've talked about it. Typical raindrop skull, punched out lesions in the skull. What is it? Multiple myeloma. What is this? Typical sunburst type of periosteal reaction, osteosarcoma. Onion peel type of an appearance, Ewing sarcoma. Ewing sarcoma, age is less than 10 years. This is around less than 20 years. Ewing sarcoma is a member of the round cell tumor family. I hope you know that. And it metastasizes to bones as well. While the most common site of metastasis of osteosarcoma is lung. And the metastasis of osteosarcoma can cavitate and can result in pneumothorax as well. Multiple myeloma, the differentiating feature between multiple myeloma metastasis is that in multiple myeloma, alkaline phosphatase is going to be normal, no new bone formation occurs, and on bone scan, it is going to show as cold spots. I hope you remember this. Now, next important set of tumors. One tumor is the geographical lytic lesion reaching up to the subarticular margin located in the epiphysis. This tumor located in the metaphysis, present in child because we can see that the bones have not yet fused. So tell me, one is GCT, the other is ABC. Where should I put my mark? Is it ABC or is it ABC? Tell me. Image number A, image number B. Yes, Rahul, you're correct. This is GCT while this is ABC. Why? GCT is giant. Giant means adult. So in a giant cell tumor is going to occur in adults, it is going to be occurring in the epiphysis. We have talked about this UGC upper end. We have giant cell tumor and chondroblastoma that occur in epiphysis. While if a tumor occurs in metaphysis, if it occurs in child, if it is eccentric in location, we have ABC. And ABC will show fluid levels. And one more sign that is given is balloon in finger sign. So this is not very important. I don't want you to remember this. The most important thing is ABC. ABC is eccentrically located in the metaphysis and it is seen in children. Why? Because we teach children ABCD. So you can just remember it by that way. Next one. This is going to be, the examiner is going to give you a history of a patient who's having a chronic abuse of steroids, coming to you with pain in left side of the hip. And many a times I've seen many of these patients recently. One of my very close friends got diagnosed with this condition. He was never on steroids. The only history was he had COVID-19, and after COVID-19 we are seeing a lot of patients coming to us like this. So what is this? Yes, this is AVN. We can see that there is flattening of the femoral head along with sclerosis. The question that is going to be asked is the investigation of choice, that is MRI in cases of AVN. What are the signs that we can get? We can get a double line sign. We can get a crescent sign which can represent a subchondral collapse, and the treatment varies upon the class of the patient, and the classification is the Ficard system of classification that we follow. Rahul, you're correct. That is classical crescent sign. Now, I want you to identify the ligaments. Where is this showing ACL or PCL? Case number 1, case number 2. Which of the following is showing ACL? So ACL and PCL we define upon the attachments of tibia. Mind you, this is a previous year question, so you should know everything about it. So I can see a ligament which is going in this direction. I can see a ligament which is going in this direction. So case number 1, is it ACL or is it PCL? Where is it attached to tibia? It's attached along the anterior aspect. So this is ACL, this is PCL. Okay. And when we look at this image, the only reason why I'm showing you this is I want you to have a look at the menisci. So this black colored structure here occurs to be the lateral meniscus. You can see the fibula here. This is the medial meniscus. And when we take the same thing in cross section, this is a sagittal view. So this is going to be the anterior horn and this is going to be the posterior horn. Ligaments, anything which is attached along the lateral aspect. This is the lateral collateral ligament. Let me use a different color for the other ligament. And this ligament which occurs along the medial aspect, black in color, is the medial collateral ligament. Now let's talk about the questions that have been asked. I think there's going to be no doubt about it. This is a classical ankylosing spondylitis. You must be in a situation to answer everything. What is this? Flowing pattern of ossification, cervical spine. The cases of that of dish, but the most common side of dish is thoracic sign. Which one do you want me to explain? Please explain again. Very doubtful. Which one exactly are you? Okay, you want me to repeat the ACL and the PCL? Rahul, I'm waiting for your answer. What do you want me to repeat? Okay, I'm still waiting. Okay, fine. Ligaments. Remember, when we see ACL and PCL in a sagittal section, we can't see it in an AP section. The examiner is never going to give you a coronal section for this. Whenever you look at the knee from the lateral aspect, you just have to look at black colored structures because ligaments are usually black except for ACL, which will show some hyperintensity. So if you see a ligament this way, which is passing in this direction, and there is another ligament which is passing in this direction. So this is the femur, this is the tibia. So when we look at the ligaments, we have to see their tibial attachment. If it is attaching along the anterior aspect of tibia, it has to be ACL. If it is attaching along the posterior aspect of tibia, it has to be PCL. I think it's going to be clear to you now. If you see any ligament in this direction, which is going like this and attaching to the posterior aspect of the tibial plateau, that is PCL. And if the ligament is attaching to the anterior aspect of tibial plateau, this is ACL. So now the last question, we already have discussed this image before, that is a classical AVN. What is this? This is typical geographical lytic lesion, and in this case the treatment that is given is vinblastine. This is a classical case of eosinophilic granuloma, but it is a difficult one. Actually, this is not my forte, but this is what we've researched. Okay, Rahul, I think it's clear now. So this is, examiner is just going to give you to identify this pathology. So this pathology is nothing but this is LCH, and the treatment that is given is vinblastine. Now let's talk about CNS. First thing is stroke. So first of all, we talk about the infarct. Anything which is not hemorrhage is going to be presumed to be infarct. So what are the signs of hyperacute infarct? Hyperacute infarct we say when it is less than 6 hours. So we can see a dense MCA which represents a thrombus. So hyperdense MCA sign. This is a MCA dot sign. We can see a thrombus within the vertical segment of the MCA. Here what we are looking at, we cannot see the basal ganglionic structures here as well as here. So this is called as disappearing basal ganglia sign, and here we can see a loss of an insular ribbon. So these are a different, this is called as the insular ribbon sign. These are different signs of hyperacute stroke. Then what is the investigation of choice? This is a very important question, something that you should be, it should be on your tips. Investigation of choice in stroke is always CT scan, never MRI. Now this is contradictory to what we think about, because the most sensitive investigation for diagnosing acute infarct is MRI with its diffusion weighted imaging. But in cases of acute stroke, we don't want to know the status of the infarct. We just want to rule out bleed, because once there is no bleed, we can directly thrombolyze the patient. And if we do an MRI, we'll lose a lot of time of the patient. So investigation of choice is always going to be a CT scan. While if examiner twists the question, very good, it's not only going to be a CT, it is going to be a non-contrast. You corrected me, KK, you're right. Most sensitive investigation for acute infarct, then it is going to be MRI with its diffusion weighted imaging. Now let's look at the other part. That is a stroke which is associated with hemorrhage. What are we seeing here? A white structure, bright structure on a CT. White is CT because bones are white. So when you see something bright on a CT, just like this, it is going to be blood. Blood, bullet or bone, BBB, are going to be bright. So it is located inside the brain. It cannot be bullet or bone. It is going to be blood. It is a case of hemorrhagic stroke. Now let's have a look at this particular image. Is it a hemorrhagic stroke? No. First of all, what is this image? We are seeing bone as white. So this is CT, and we are seeing a part of a brain which is a wedge-shaped area which is completely hypodense. So this is an infarct. What is this image? What is this sequence? This is an MRI sequence which is shown in couplets. Why it is not T1 or T2 sequence? Because in T1 or T2 we'll find scalp fat as white, while here scalp fat is black. Why it is not flare? Because in flare we would be able to see the bone. Here we are not seeing anything. So it is a diffusion weighted sequence, and an acute infarct would be this like very bright on diffusion weighted imaging and will be very black on ADC. It is not flare, mind you. In flare you'd be able to see the bones very clearly. Here you're not able to see the bone. No susceptibility. Susceptibility will show black spots. We'll be talking about susceptibility with imaging later on as well. So this is not susceptibility. Why it is not susceptibility? We'll be talking about it later. Now, three different ways in which traumatic bleeds can present. This way, which is a typical lemon, this way, which is a crescent, a banana, and this way in which you can see blood inside the subarachnoid spaces. This is EDH, this is SDH, this is SAH. What are the important points you need to know? EDH caused by damage to middle meningeal artery, so occurs after strong trauma. SDH, it is because of trauma to the cortical bridging veins, so it occurs even after trivial trauma. SAH is basically over the subarachnoid spaces. Now tell me, in this case, which of the following crosses the sutures? Which will cross the sutures? Rahul, you're correct. That's EDH. Perfect. You're correct. EDH, SDH, SAH. Which of the following cross the sutures? This particular bleed will never cross the sutures. EDH never crosses sutures, while it can cross midline. Never crosses sutures, but can cross midline. SDH can cross the sutures, but cannot cross the midline because dura is like this here. So SDH will come here and it will stop here because there is a dural fold anteriorly. While EDH is occurring outside the dura, so it says how will you limit with dura? Go away from me. So it will split the dura and result in it can even cross the midline. We can have syndromes like talk and die syndrome and lucid interval which are associated with it. SDH, remember, can cross the sutures but does not cross the midline. Now, this is what sequence? Tell me, what is the sequence? Fast. We don't have time now. I know you're getting bored. It's been already around 2 hours. Time went past by quite fast. What is the sequence? Now I tell you, this is a history of a patient who came to you with a trauma, and the patient is in a very poor state, very poor GCS, and CT of the patient was normal. Now they did the MRI of the patient, and this MRI is showing you all this. So you can see multiple punctate bleeds. So this is a classical case of DAI, diffuse axonal injury. Mind you, in diffuse axonal injury, the investigation of choice is MRI. While for all other cases, if the examiner asks you what is the investigation of choice in head trauma, it has got to be a CT scan. Sometimes the examiner can also give you a CT scan. This is a CT because bones are white here. So bones are white. So you can see multiple small bleeds at the gray white matter interface. This is how DI will present. And this sequence is what? We've talked about this MRI. We've talked about this being DI. Tell me what is the sequence? No, that's not diffusion weighted imaging. You're not seeing diffusion will always come with couplets. There will be ADC map along with diffusion. There's no couplet here. There's only one image. There's no pair here. All what we can see is multiple black dots. So if you see multiple black dots, diagnosis is a susceptibility weighted image. So this is a susceptibility weighted or a T2 star image, which is basically done for cases of suspected DAI. Now pattern of calcifications in brain. If you find these type of calcifications which are just looking like gyral tram tract calcifications in a patient with port wine stain with epilepsy, tell me the diagnosis. Case number 2, a patient coming to you with adenoma sebaceum, patient who's coming to you with mental retardation, and you find these type of calcifications, tell the diagnosis. A patient coming to you with seizures, case number 3, tell me the diagnosis. Case number 4, a child who's born, a fetus who's born now, a neonate who's having microcephaly, who's having problems with the eyes. What is it? Raul, perfect. That is tuberous sclerosis because we can see some subependymal calcifications. Case number 1, tell me, port wine stain coming to you with brain calcifications, seizures. Case number 3, only presenting with seizures. Yes, case number 3 is NCC. We can see multiple ... giving rise to a starry sky appearance. And for NCC, we use the Escobar staging. This is also very important, Escobar staging. Now, the 1 and 4 are left. What is 1? 4 is not Zika, 4 is CMV because we can see periventricular calcifications. Tell me number 1 now. Only one we are left with. What is it? Rahul, you're correct. That's CMV. One is Sturge-Weber syndrome. Port-Weinstein is the most important feature, the clinical hint that the examiner is going to give you. A neonate presenting to you with pulsatile pulsations over the head. I mean, auscultations. You can see a bruit over the anterior fontanelle, and you see this particular thing on CT and this particular thing on MR, dilated vascular structures. Diagnosis. Tell me the diagnosis here. A neonate with a bruit over the forehead. You can see an abnormal vein draining into the torcula. Yes, you are coming right. Should I give you a hint? Bog. Vein of Galen malformation. That's a vein of Galen malformation. So coming back to the questions. Diagnosis. I don't think that there is any doubt. This is a typical cystic lesions seen on T2-weighted MR. Neurocystis. Next one. Patient coming to you with very poor GCS, no fractures, no signs of raised ICT, NCCT was normal. I don't think there is going to be any doubt. Yes, Rahul, you're correct. That was vein of Galen malformation. Diagnosis here is, yes, diffuse axonal injury. You correct, KK, that's A. Now let's talk about the sequence. What do you see in the sequence of the brain? It cannot be T1, T2 because we don't see any white scalp fat. Secondly, it cannot be a diffusion weighted imaging because we do not provide it with pairs. What we can see some black areas. What is the diagnosis? Yes, perfect. Now you're done. You're mastering it. That's a susceptibility weighted image. Now coming to GU radiology. A spotter. What do you see here? What is a spotter? KK, you're correct. That's a horseshoe kidney. And you can see that both the kidneys are fused at the level of L3 vertebra. What are the various type of calyces that you see? What are the signs? The signs that are, yes, you're correct. Everybody, if you've got it correctly, that is a susceptibility weighted imaging. So when both the kidneys come together, they are friends of each other. They want to stay together. So we have a handshake calyces or flower vase type of an appearance. These horseshoe kidneys are not located at back, so there are an increased risk for all sorts of troublesome things like transitional cell carcinoma, like infections, like trauma, like calculi. So this is a classical spotter that the examiner is going to give you of horseshoe. 5 different images, 5 different diagnoses. I want you to tell me 1, 2, 3, 4, 5. What are they representing? All of them have been asked in the exams, so they should be on your tips. Case number 1. What is it showing? Fast. I'm waiting. Now it's going to be around 8 o'clock. All of you would have to go for lunch also, na? Sorry, dinner also, na? I'm sure you must have had your black coffee or your Red Bull. You want to have a water? You want to have a break? Just let me know. Okay, DMSA. We'll be talking about DMSA, RGO, and MCU. I'll be talking about that later. No, none of them is neurogenic bladder. Okay. What do you see here? What is this snake coming down? That's a hint. Adder head, Nag. Case number 2. Beautiful appearance, just like a maiden weight. What figure do you expect from a maiden? Is drooping lily. Perfect. You got it correct. Kiran Jyot is definitely correct. That's an adder head appearance. It represents uretrocele. What is this? Typically like a maiden waist. So this is a maiden waist deformity. Where do we find it? We find it in cases of, yes, we find it in cases of retroperitoneal fibrosis. Case number 3, you've already answered it correctly. Drooping lily. D for drooping lily, D for double moiety. I hope you will remember this. D. Case number 4. What has happened to the kidneys? This is a CT image. The kidneys are so large. Multiple cysts, I should say cyst, and we can also see, no, this is not retrocaval ureter. Retrocaval ureter is going to be something like this. It's going to have a fish hook type of a deformity. It's not retrocaval. This is, what is this? Case number 4. Large kidneys, you can see cyst in the kidneys, you can see cyst in the liver. This is ADPKD, where you get the Swiss cheese nephrogram, spider leg pyelogram. Perfect. Rahul has pointed it correctly. Case number 5, kidneys here and large pelvis here. This is a PUJ obstruction. It is not a stone, remember, because we can see contrast in the kidneys. It is a CT urography image. How does stone look? We'll be talking about that later. Now, 3 different images. No stardust, it's not staghorn. This is what I was pointing out. That's to answer your question. I have shown you 3 different images. Case number 1, 2, 3. Tell me, what is one representing? Case number 1. Take your time. I'll tell you, this is a patient who's coming to you with sterile pyuria. Sterile pyuria. Very good. That's putti kidney. Why it is putti kidney? Because the entire kidney has calcified. While this second one, it doesn't look like a renal calcification. In fact, it looks as if there is calcification in the calyceal system. You can see the renal markings outside, and this entire calcification is occurring inside the pelvic calyceal system. So what is 2 representing? Now your point is going to be correct, Stardust. It is a Staghorn calculus, which is a triple phosphate calculus. You can call it true white stone caused due to the continuous infection by Pseudomonas and Klebsiella. It is a painless condition. Case number 3, what it is? It is a bilateral condition. Now this is important. It has been asked previously. I want you to tell me what it is. Case number 3. Does it look like a stone? No, it doesn't look like a stone. Does it look like a putti kidney? No, it doesn't like a putti kidney. We have calcifications, but these calcifications are interspersed within the renal parenchyma. So when you have multiple calcifications interspersed within the renal parenchyma, it is a case of nephrocalcinosis. And you get various signs like a paintbrush appearance. This is really not required like Favre's appearance. The only thing you need to require is you need to differentiate the 3. Is there any confusion? I can go ahead. You will be able to differentiate between these 3 conditions. Okay, perfect. Now, coming on to renal tuberculosis. Most sensitive investigation of early changes of renal TB. It is IVU. What are the signs that we get in IVU? We can get moth-eaten calyx, amputated calyx, stumped calyx, hydronephrosis, but this is not what the examiner is going to ask you. Examiner is going to ask you only this. Overall best investigation, CT urography. Most important clinical clue. This is my work. I'll tell you what the clinical clue is. Sterile pyuria. Earliest sign on IVU, we've talked about it. That is moth-eaten calyces. Moth-eaten calyces or moth-eaten calyx. Other signs you can again get, I just told you, like stumped calyx, amputated calyx, phantom calyx, which is not really important. Now, ureteric signs are left. So again, in ureter, you can get all sorts of fibrotic elements like corkscrew ureter, Kirk's king. You can also get pipe stem fibrosis in ureter, Goldfall ureters, and thimble bladder. So these are the things which you also need to know, like corkscrew, Kirk's king, pipe stem, and Goldfall ureters, and small size thimble bladder. Coming on to renal tumors. If you see this type of a renal tumor which is black as subcutaneous fat, you're talking about a fatty tumor, AML, angiomyolipoma. If you get this type of a tumor which contains a scar, it is scar for oncocytoma. And if you get a large tumor, examiner perfect, Kiran Jyoti, you're correct. If the examiner gives you a hint, an elderly male coming to you with hematuria, chronic smoker, you know you're dealing with an RCC. Questions that are asked is, investigation of choice in RCC is definitely a CT, but for tumoral thrombus, the investigation of choice in thrombus is an MRI. Okay. If the angiomyolipoma goes very large, it ruptures. It's a syndrome which is called as Wunderlich syndrome. Perfect. KK is getting it perfectly correct. Now your point, how to differentiate between RGU and MCU. So you see this type of a case in which we have given contrast to the urethra. Now tell me whether this is an RGU or an MCU. MCU, what is the full form? Micturating cystourethrogram. Cysto, what is cysto standing for? Bladder. So if you have contrast in bladder, it is going to be MCU. If you don't see contrast in bladder, it is going to be RGU. So tell me whether it is RGU or an MCU. Fast. It's going to be clearing all your doubts about it right now. So because we cannot see any contrast in the bladder, it is a RGU. But what is this thing showing us? Yes, Rahul, now you're getting correct. We can see a significant amount of contrast is coming outside the urethra. If I tell you this is a patient with road traffic accident coming to you with blood at meters, then what are you going to tell me? What is the diagnosis? It's a urethral rupture. Would you do an MCU in urethral rupture? Would you put a Foley's catheter in a suspected urethral injury? Never ever, because you will complete an injury. You can make a partial injury into a complete injury. This is the second case. Now what are we looking at? Now you can be confused. Either it can be, you're right, Rahul, it can be an IVU or it can be something else. So let us look at what are the things we can find out. What are the areas where the contrast is showing? Contrast is in the kidneys, it is in the ureter, it is in the bladder also, but it is there in the dilated urethra. So tell me, can contrast come inside the urethra in an IVU? IVP or IVU shows you kidneys, ureters, bladder. Tell me what is this investigation now, where you have contrast in the bladder, in the kidneys, as well as in the urethra. Fast. Is it an RGU? Is it an MCU? Or is it a IVP? Come on, I'm waiting for it. Perfect, Kiran. Now I think Rahul, you've answered your question itself. Now there's going to be no doubt about it. If you see contrast in the bladder and urethra, it is MCU. If you see contrast only in this urethra, it is RGU. If you see contrast in the kidneys, ureter and bladder, but not in urethra, that can be IVU. And what is this? What is this image showing you? This is showing you reflex of contrast from the bladder into the pelvic calyceal system. It is a case of VUR. Investigation of choice in VUR is a MCU. So just a quick revision of what we studied. Urolithiasis, investigation of choices NCCT KUB. Hydronephrosis, investigation of choices ultrasound. Any valve and VUR, MCU. Urethral injury, RGU. For testicular torsion, we need to do a Doppler study to see whether there is blood flow within the testes. So this is an old smoker presenting with hematuria and vague pain in right flank. So this is a typical case of RCC. Diagnosis is clear cut. I don't think there's going to be any issue. Now here there is an echogenic lesion, and look at this opacity, or I should say the attenuation of this particular lesion. It is black as subcutaneous fat. Diagnosis is renal angiomyolipoma. Last, what do you see this particular lesion as? You can see multiple cystic cobweb type of an appearance. So it is a classical case of hydatid cyst. In hydatid cyst, should you do a biopsy? No, we cannot do. Yes, there is a hypersensitivity. There can be marked hypersensitivity action to the contents that they leak in the abdomen. So this is correct. And biopsy should be done. This is definitely incorrect. Albendazole, yes, disease is caused by duct tapeworm. Rest of them is correct. I think this is going to be very clear to all of you. Last but not the least, this is the question we just talked about. Per urethra Foley's catheter was administered, but there was minimal urine output. What is the next best step in management? So first of all, this is a patient who is coming to with suspected urethral injury, and what you've done is you've done a big mistake or a blunder. You tried to put it a Foley's catheter. Now what it is showing? It is showing a complete rupture of the urethra. What is the area of urethra that is ruptured? Let us quickly revise the segments of urethra. The longest is penile. After that is bulbar. Then there is membranous, and finally we have this prostatic urethra. So the membranous urethra is ruptured here. So what are you going to do? You have no other option. Now you cannot pass a catheter. You've already done a blunder. So you'll have to do a suprapubic catheterization, because the patient will need to urinate from somewhere at least. So suprapubic catheterization is the answer. Now just summing up, in the last 5 minutes, we'll be talking about the basics. Name the investigation shown. Is it ultrasound, X-ray, MRI, or fluoroscopy? I think there's going to be no doubt about it. We can see the typical soft tissue appearance of thyroid. We can see some arteries appearing as black vein. So it is an ultrasound. X-ray will show you air as well as bone. So this is not an X-ray. MRI it's a cross-sectional imaging. It is not going to show this type of an appearance. Fluoroscopy is also an X-ray image. All of you are getting it correct. Perfect. That's an X. Now MRI or CT, not difficult questions. So look at these two dogs. One is white, the other is black, fighting over a bone. Why? Because MRI and CT are also fighting over a bone. If you have to look at the bone, look at the cortical outline of the bone. If it is black like this, it is MRI. While bone can never be black on CT, because CT is an X-ray, and since childhood we are looking at X-rays. So X-ray will show bone always white. The cortex is the inner aspect. Well, if you see the outer aspect or the cortical outline is black, we are talking about an MRI. Now, NCCT or CCT, image number 1, image number 2. What is it? So to understand this, we give contrast intravenously. So if we have to judge whether there is a contrast CT, we have to look at the vessels. So we look at the aorta. So case number 2 is contrast enhanced CT. And for doing a contrast enhanced CT, what is the prerequisite? Creatinine. And it is also a requisite for contrast administration in MRI. Otherwise, the patient is going to develop a lot of reactions. In CT, patient can develop contrast induced nephropathy And in MRI, he can develop nephrogenic systemic fibrosis, a dreadful entity, a very, very bad entity. So this is a non-contrast study where you don't see any contrast in the, you're correct, Kiranjo, that's RFT that we need. Plus, if it is a female patient who wants to get a CT done, what you need to do? You want to check the LMP, because we cannot do a CT in case of a pregnant patient anyhow, because it includes a lot of radiation. What is this investigation? It is a CT because we can see bones as white. But what is happening in the CT? Anybody? Kiran, Rahul, KK, Stardust, anyone? We can see a lot of white contrast inside the cranial cavity. It is done specifically for those patients who are suspected of having CSF leaks. What is it? It is CT, expert, you correct, that's a CT, but it is a different, it's a modification of CT where we're giving some contrast starting from the spinal canal. We're doing a lumbar puncture, and then we are just asking the patient to lie down in a head-low position so that contrast reaches into the subarachnoid spaces and the ventricular system to look for CSF leak. This is a CT cysternography. CT cysternography. Next. Now we'll learn to identify the MR sequences. So if you see this scalp fat as white, we are talking about T1 and T2. Rahul, you're correct. That's CSF rhinorrhea, but that investigation is that we do is CT cysterno. So this is T1 and T2. And what is the mnemonic that we have? World War II. Water appears white on T2. So this is a T2 weighted sequence. This is a T1. Automatically it becomes a T1 weighted sequence. Now, how do we identify flare? In flare means fluid attenuated inversion recovery. So we attenuate fluid, but the bone will be seen. So bone will be seen as black and everything else will be attenuated. That is, CSF will be attenuated, scalp fat is also attenuated. That becomes flare itself. Now let's look at these two images. Now you may ask me, sir, why this is not flare? Because although we can see this black appearance, no, stir, Kiran, we don't use in brains. Stir is typically used for MSK imaging. Here we can typically see black appearance of CSF, but where is the bone? We don't see any bone. Look at the bony outline, very well seen on this flare image. So this image is a diffusion weighted image and it always comes in pairs. Remember, examiner will always give you this in pairs. So this is an ADC map and this is a diffusion weighted image. I hope everybody of you will now follow this. This is a flare image. How to identify T1 and T2? Look for the scalp fat. This outside, this fat over the scalp. If it is white, either it is T1 or it is T2. Then look for CSF. So water appears white on T2. If CSF is black, you're talking about a T1. If CSF is white, we're talking about a T2. Then look at another image. If everything is black, either it can be obviously a diffusion weighted image or it can be a flare sequence. But if you see the bone, again, because flare is nothing but a modification of a T2 weighted sequence, so we'll be able to see bone. But in diffusion weighted imaging, we won't be able to see bones. Now we've seen this image before also. What is it representing? It is representing an acute infarct, an area which is showing hyperintense signal with a signal washout on ADC maps. Now this image, what, tell me now, this you should be telling this now. Multiple black dots. What is it? What is the sequence? The sequence is a susceptibility weighted imaging. I hope you will never forget this now. Now, next sequences. When you see an ultrasound based, yes, Kiranjot, you perfectly corrected. It is a case of DAI and the sequence is a susceptibility weighted image. What do you see here? It is a colorful image of ultrasound. So whenever we see color in an ultrasound, it is going to be a color Doppler, typically used for vessels. And if you have this type of a graph appearing in the vessels, then this is a spectral Doppler which has been taken. Now sometimes the examiner asks you arterial and venous waveforms and what is the difference. So this is the typical arterial waveform, which is going to be somewhat like this, while a venous waveform will be dead, just like a barcode that we saw. It is going to be monophasic, while this is triphasic or biphasic. Yes, you're right, Kiranjot. If you see these two images, if you see this orange or brownish color, you can see whatever you call it. So what is this investigation? It is a modification of an ultrasound based image. What is it? It is you're giving some contrast in the ultrasound. So this is a contrast enhanced ultrasound. What is this image which is showing you some hardness in pascals? If you are good at physics, you must have read this Pascal thing. Pascals is a unit of stiffness or hardness. So if you have an ultrasound based image with a color coded map and a Pascal is given, you're talking about elastography. And a modification of elastography is Fibroscan. We use Fibroscan for measuring liver stiffness in patients with suspected cirrhosis. So with this, we finish our short, I won't say a short discussion, a long discussion about radiology. And in this particular session, I've tried to actually cover out everything, the most important topics that have been asked in your recent year exams, and the most important things that you need to know just before you go and you give your exam. So hope this session was a good one. I want you to just go through this particular session once again, because it's going to be up on YouTube before you go for the exam, because this will contain all the most important previous year questions that have been asked so far. So just keep scrolling over it. Tomorrow we'll be coming back, joining you again for a fantastic pediatric session. And I hope that the zeal, the learning experience is as good as always. All the participants that have been there have answered almost all the things correctly. So as far as radiology is concerned, I have no doubts that majority of you will be coming up with shining colors. So this was a really fun session, and I really enjoyed working with you. I really enjoyed having this interactive session with you. So yeah, thank you everyone for joining the session tonight, and I hope that it's added some more meaning, some more knowledge to your already running quest for INICET. So let's call up this session, and I hope that you also go towards the Medace app and just go and download it and look at the few important contents, because whatever we've talked about this was just a very small quick session. We've discussed everything, we've made notes, we've done a lot of hard work in the MCQs as well, and we'll be doing the same for you in future as well. So we'll be looking after INICET results, and I hope that majority of you will turn up with shiny colors and probably will take radiology as your core subject. Radiology is an interesting subject, although it is not considered interesting in the undergraduate level. Thank you everybody. Thank you for joining me.